Thank you so much for joining us today for an exciting session to learn more about hematological malignancies, also known as blood cancers. Now, advances in the field of oncology, and specifically within blood cancers, are growing by leaps and bounds, and it is our collective mission here at Grace to really bring to the forefront to the patients and their caregivers all the advances in the field in terms of diagnosis about the disease as well as treatment in a manner that is palatable for patients and caregivers as well. So that's the whole reason for the endeavor for this GRACE program. Now, I've been a part of GRACE for almost 2 years now in doing patient education videos and very grateful to be a part of this organization. Myself, with some other panelists, have been a part of GRACE for some time now, and I have participated in this Blood On Talk previously and thoroughly enjoyed it. So I really hope that today everyone who's logging in find a lot of value and benefit in some of the stellar topics presented by our amazing speakers today. So with that, we'll get our program started. And I just wanted to send a huge thank you out there to our generous sponsors who are responsible for supporting this event. And they include Lilly Oncology, Janssen, Merck, and AbbVie. Now, I would like to introduce our panel of speakers in the order in which their talk is presented for today. And I can start with myself. My name is Sridevi Rajiv. I'm an assistant attending at Memorial Sloan Kettering Cancer Center at the Myeloma and Cell Therapy Services. I'm primarily a hematologist, oncologist, and a physician researcher who specializes in plasma cell disorders and has expertise in cellular therapies. And my research interests include leading clinical trials in multiple myeloma, CAR T cell therapy, digital health, and healthcare delivery transformation as well. And as a side note, I was a GRACE Fellow from 2022 to 2023. Now, I want to introduce the first speaker, Dr. Hamza Hashmi. He is one of my colleagues at Memorial Sloan Kettering Cancer Center. He's an assistant attending in the myeloma and cell therapy services as well, and previously was at Medical University of South Carolina. His areas of interest include real-world evidence for therapies in multiple myeloma and leading cellular therapy trials. And Dr. Hashmi has collaboratively led many studies for real-world evidence that we as myeloma clinicians use in our practical life. So welcome, Dr. Hashmi. The next speaker after Dr. Hashmi is going to be Dr. Michelle Stenchina. She is an assistant professor in the Division of Hematology at the University of Miami who focuses on lymphoma. She's currently working on multiple projects in the field, including examining healthcare disparities among patients with diffuse large B-cell lymphoma and, with a special focus on decreasing toxicity for patients undergoing chemotherapy in lymphoma with a focus on Hodgkin's lymphoma by giving them a sort of abbreviated chemotherapy and evaluating outcomes. Welcome, Dr. Stenchina. The speaker after that is going to be Dr. Muhammad Salman Faisal. He's an attending physician in hematology and stem cell transplantation at the Oklahoma University Health Stevenson Cancer Center. Dr. Salman Faisal is interested in multiple myeloma and is specialized in transplant and cellular therapy with a special interest in expanding access to care for patients. Education has been a cornerstone of Dr. Faisal's career with many endeavors he's been involved in with ASCO and now at GRACE as well. Last but not the least is Dr. Andrew Srisuwana-Nucorn. He is an assistant professor in the Division of Hematology at The Ohio State University, as well as a member of the Leukemia Research Program and an affiliated member of the Translational Data Analytics Institute. He specializes in treating patients with rare blood disorders, including myeloproliferative neoplasms, myelodysplastic syndrome, MPN MDS overlap, and systemic mastocytosis. So for those listening, these are all rare cancers within the huge umbrella of leukemias or blood cancers. Dr. Srisuwana-Nucorn is also a quantitative scientist, and his research entails developing ethically appraising new artificial intelligence and machine learning algorithms to address common clinical dilemmas faced by patients and doctors. So that's the whole stellar lineup we have for you. And without any further ado, I hand over to Dr. Hashmi to talk about Multiple Myeloma 101, Facts and Fiction of the Myeloma Marathon. Dr. Hashmi?
Can you see my screen?
Yes.
Okay. Right. Very warm morning, everyone. First of all, thank you, Dr. Rajiv, for the kind invitation and introduction. I'm Hamza Hashmi. I'm a physician at Memorial Sloan Kettering. Um, in my practice, I see patients with multiple myeloma, smoldering myeloma, and MGUS. And today I will be talking about the basics of myeloma, the diagnosis, presentation, the risk factors. I'll also briefly talk about the principles of myeloma treatment, as we call them, the do's and don'ts of myeloma, and then briefly touch upon the role of bone marrow transplant, where why do I believe that stem cell transplant is the Tom Brady of myeloma treatments. We'll chat about relapsed myeloma, and then we'll also talk about some of the basics of CAR T and bispecific antibody treatments for myeloma. My philosophy is that when I give these presentations, I actually tailor them to my audience. I don't like to drown my audience in numbers, stats, figures, and data, but in fact give them highlights, summaries, and take home messages. I share some pearls of wisdom from the grandma's old recipe book. And then finally, I'm a myeloma doctor in 2024. So you will see a lot of memes in my presentation and hence the identification as a millennial. So let's start off with a real life patient of mine's study. A 65-year-old female, a school teacher who actually came in to see me for a consultation for relapsed myeloma. The patient has had many different lines of therapy, at least 7 that we could count, including a bone marrow transplant previously. The patient presented with significant anemia, very short of breath, very fatigued, very tired, that you see with anemia oftentimes. We performed a bone marrow biopsy that showed about 90% plasma cells in the bone marrow. She was having a lot of bone pain, so we did a whole body PET-CT scan that essentially showed the skeleton to be riddled with bone lesions. Um, I discussed the option of CAR T cell therapy with this patient, and I asked her what her motivation was for pursuing that treatment. And she told me that she has her very first grandchild on the way in about 6 months' time. And she wants to make it to that day so she can hold the grandchild in her arms. What happens to this patient, whether she goes to CAR T or not, what happens during CAR T, and whether she is able to live up to that day, we'll find out by the end of this presentation. I'll keep it there as a suspense. Moving on to myeloma. Multiple myeloma is a group of plasma cell disorders. All plasma cells are essentially white blood cells that are grown up, mature, differentiated. They perform the essential function of making antibodies that fight infections. Um, there are 3 different kinds of blood disorders in this plasma cell disorder spectrum, including MGUS, smoldering myeloma, and symptomatic myeloma. The big differences between the 3 is that in MGUS, we usually have less than 10% cancer cells in the bone marrow. They make small amount of protein, but it doesn't cause any major damage to the body. In patients who have smoldering myeloma, they tend to have more than 10% cancer cells in the bone marrow. They make protein a bit more than what we do in MGUS, but that does not cause any damage to the body organs again. And what happens in multiple myeloma is that anytime we have more than 10% cancer cells in the bone marrow that makes protein that causes damage to important organs in the body, we define it as myeloma. Important thing to remember is that all patients with myeloma start off with a precursor condition known as MGUS. Typically, it's 5 to 10 years prior to that diagnosis of myeloma. My patients ask me all the time, did I acquire it last night or last week or month? The answer is no, it's been there for a while in the body as an MGUS. Let's walk through the corridors of history to give you some historical perspective on this blood cancer. The very first time in history that we stumbled upon a case of myeloma was back in 1844, when a young female presented with debilitating bone pain, eventually succumbed to the bone pain, and upon autopsy was found to have a giant red tumor in her pelvis. The tumor essentially melted under the autopsy knife, and that autopsy report actually is a part of historical archives now. 100 years later, we did the very first randomized clinical trial for multiple myeloma. That was again in 1950s, where we gave patients with myeloma either the chemical urethane or placebo in the form of Coca-Cola. And for the very first and perhaps the very last time in history, Coca-Cola made people live longer. Uh, simply because the chemical urethane was too toxic for the myeloma patient. And we learned the lesson not to do any harm to our patients from that trial. Fast forward 2002, we have two myeloma drugs. 2024, we have 25 drugs in 50 different combinations. As Dr. Rajiv alluded to it earlier, they have been exponential leaps and exponential advancements in myeloma. And that is what has actually provided us with all these therapies in modern times and age. Sometimes I talk to my myeloma patients and I tell them that the treatment options, when I look at the guidelines, remind me of the Cheesecake Factory menu. There are too many options to pick from. Few facts about myeloma is the 10% of all blood cancers, second most common blood cancer in US. About 35,000 people get diagnosed with myeloma every year, and 7,000 folks actually do a bone marrow transplant, and nearly 13,000 people die with this cancer every year. In 2005, average survival for myeloma patients was around 2 years. In 2015, survival improved to 5 years. In 2025, we are expecting the average survival for a myeloma patient to be 15 years and beyond. Risk factors for myeloma, primarily, in my opinion, is age. As we all age, we acquire exposure to chemicals, to radiations, to pesticides, to infections and autoimmune conditions. Any and all of them can actually trigger mutations in normal plasma cells and make them into a cancer. So as we age, we acquire this cancer. Having said that, higher chance of developing in men above age 50, and men who have some family history. There's a very small fraction of myeloma patients who actually have a genetic predisposition. Typically, they happen to be African Americans, young females who have known family members. We don't yet know what these mutations are, how to test for them, and whether all other family members need testing for it. But we do know there is a small fraction that is familially predisposed. I like to define the myeloma journey as a marathon with many uh, peaks and rises, many mountains and valleys, remissions and relapses. This slide shows you that how patients transform from an MGUS-like state to a smoldering myeloma and eventually become symptomatic myeloma. As they go through treatment options, they get into a remission, a control of their myeloma. That works for a while, and the myeloma eventually relapses. Some clinical presentation features to go through for some of the audience members here. Most common presentation for myeloma happens to be anemia. You're fatigued, tired, short of breath, with minimal exertion. Two-thirds of the myeloma patients with prevented myeloma bone disease is typically severe bone pain, either in your spine or your hips. Sometimes it can involve an arm or a leg as well. But the pain tends to be unremitting, unrelenting, not relieved by ibuprofen, Motrin. It wakes you up at night and doesn't let you go back to sleep. That's the classical features of myeloma pain. Very different from the aches and pains we all feel every day as we go through life. Kidney failure can be seen in 20% of the folks. Typically, we stumble upon it as patients are seen in the hospital. And finally, high calcium can be seen about 15% of all folks. When I see that, it reminds me it's a very advanced stage myeloma. High calcium in isolation without any of these other features is unlikely to be myeloma. Historically, we have defined myeloma as presence of a malignancy that is proven on a biopsy, either a bone or a bone marrow biopsy, and evidence of damage to the organs in the form of the CRAB. CRAB here stands for high calcium, renal failure, anemia, or bone lesions. If you have biopsy proven cancer in any one of the four, you have myeloma. In 2014, we learned that there are patients out there who have evidence of cancer on a biopsy, do not have any organ damage in the form of a CRAB, but have either a very high amount of cancer in the bone marrow or a very high amount of protein, or have MRI showing lesions that look like myeloma. If you have any one of these features in 2014 onwards, you will be declared a myeloma patient where you should go through therapy. Reason for that is that patients who have these features without organ damage are at very high risk of organ damage. We choose to call them myeloma and treat them like myeloma. Hence, the CRAB up until 2014 was slim, was 2014 onward has become a slim CRAB. Some of the principles of myeloma treatment, the goal of treatment is actually control of myeloma, not cure of myeloma, because we believe cure is not something that we have can reliably achieve for this cancer in a vast majority of our patients. We like to do 4 drugs for treatment at the onset of treatment. We like to do transplant early on for these patients as well and keep them on maintenance for the foreseeable future. When I see any patients with new myeloma, the very first thing I do is I determine whether that patient is transplant eligible or not. And secondly, whether they have high risk or a standard risk myeloma based on the mutation testing on bone marrow. So it's very important to get those testing done with your physician to know what kind of myeloma we are dealing with. This is a treatment algorithm that we follow at our site at MSK, that every new myeloma patient at the time of diagnosis gets stratified into transplant eligible or ineligible, standard risk myeloma or high risk myeloma based on the bone marrow mutations. If you happen to have standard risk myeloma, we choose to give 4 drugs because of all the recent evidence we have seen with that regarding the effectiveness of 4 drugs. And if you happen to have a high-risk myeloma, we'll replace the bortezomib chemotherapy with carfilzomib. We usually give 4 months of chemo. That's the first stage. Then we go on and collect the stem cells and take patients to bone marrow transplant. The transplant process takes about a month, but we do give a break of about 2 months after it's completed. And then after this transplant is complete, we remove the patients to the third stage of maintenance chemotherapy, which patients continue until myeloma comes back again. If you happen to be a transplant ineligible myeloma, we again stratify you as a high risk or a standard risk myeloma. Standard risk myeloma tends to do very well with 3 drugs alone. With high risk myeloma, we choose to give 4 drugs for about 6 to 9 months. And if you see a very good, very deep remission, we again move you on to 3 drug maintenance chemotherapy. We continue this chemotherapy as long as myeloma remains in remission and you tolerate chemotherapy well. What is the role of transplant for myeloma, or why do I choose to call it the Tom Brady of myeloma? I call it a Tom Brady of myeloma because if you want to win the game and carry the trophy home, you want to bring him early on in the game. Don't expect a Tom Brady to come in the last 5 minutes and carry the trophy home. This is based on 2 large randomized clinical trials that were done in US as well as in Europe that looked at the question of early versus late transplant for a new myeloma patient. Early transplant means that we are doing it after 4 cycles of frontline chemotherapy, and late transplant means doing it upon relapse 4 or 5 years later. Both trials showed us the same result. If you do an early transplant, which is within 4 cycles of chemo or 6 months of your diagnosis, you tend to get into a deeper and a longer remission, which can actually last 7 years in modern times and age. Having said that, it does not necessarily make you live longer compared to folks who don't do transplant early on. With a caveat that patients who actually have a high risk myeloma, there is a significant benefit of transplant when compared to not doing the transplant. And that's a group of patients we strongly recommend transplant. I put all of my thoughts regarding the role of transplant for a new myeloma patient in this article. It was published where I go through the reasons why we should do transplant early. Um, just to summarize this, I believe most myeloma patients, especially when they're in their late 60s, early 70s, they only grow older with time. As they grow old, they acquire more comorbidities, more medical conditions, they lose their medical physical fitness, they may not have a caregiver, may not be able to collect stem cells. So I like to get the transplant done early so that we can avoid all of these problems later on in life in case we need transplant. The only time I may choose to collect stem cells after about 4 to 6 months of chemotherapy and keep it reserved for a rainy day is when I have a young patient, a fit patient with good kind of myeloma who has a very strong reason, social reason, family reason to delay transplant. But again, I recommend collecting stem cells after 4 to 6 cycles. Moving on to the maintenance chemotherapy, as of now, the ritual in US is that we start maintenance with chemo pills with or without injections of chemotherapy and continue them till the rest of the patient life, as long as the myeloma is responding and a patient is tolerating. Having said that, there are multiple trials going on at different sites in the US, including MSK, that are looking at limited duration maintenance. What we have learned from them is that if you do 2 years of maintenance chemotherapy and you run a bone marrow special test that shows deep level of remission, you can actually reliably stop maintenance chemotherapy. There's a big trial that I participated in where I was in South Carolina that's looking at nearly 1,500 patients where they're stopping their maintenance after 2 years. and see if they relapse or not. I think we'll know from this trial result in the next 3 to 5 years, where we will know what to do with the duration of maintenance chemotherapy. But in my practice, if I have a patient who has had 2 years of maintenance, is in a deep level of remission based on bone marrow biopsy test, and is interested in stopping maintenance, I am open to that idea and discussion. Let's talk about some of the basics of myeloma regarding some of the complications, vaccines, and infections. Myeloma bone disease is common, usually affects your spine and your pelvis, can be debilitating. Radiation therapy is a very effective remedy for it. I also look into kyphoplasty, which is a procedure where they can actually inject some cement and numbing medicine into your bone, give it more structure, give it more strength. And then I also have my patient go on bone modifying therapy in the form of Zumata and Xgeva on a monthly basis. We give them some calcium, vitamin D. We make sure they have dental hygiene with it. Infections are very common. They happen because immune system is compromised with myeloma and myeloma therapy. Every patient should be on acyclovir or valacyclovir to prevent shingles. And I strongly recommend discuss with your physician when you can get Shingrix vaccine. I typically tend to avoid that in patients who are on chemotherapy. I strongly recommend influenza vaccine, COVID vaccine, as well as RSV for myeloma patients. And then some chemotherapy related side effects, which are very common. I hear from it my patients all the time. I just want to quickly walk you through those as well. Cramps that you notice oftentimes in your hand and your feet into nighttime. They're related to Revlimid and Pomalyst like chemotherapy. Tonic water, mustard mixed in water, pickle juice are some of the remedies that have worked very well for patients. Neuropathy is a very common side effect. If you've been getting bortezomib-based chemotherapy twice weekly, it happens in nearly 60% of the folks. I recommend my patient taking some medication to help relieve the pain, walking long distances, because every time you are stationary, you are immobile, that pain gets flared up. Cancer-related fatigue is a very common phenomenon. All patients who have some sort of malignancy are getting chemotherapy for it will have some degree of fatigue and weakness. The answer lies, and I know it sounds counterintuitive, in physical activity. I'm asking my patients to do exercise when they're fatigued, but trust me, it works. Going to a gym, working with the therapist in the gym, participating in activities like swimming is very helpful. And finally, chemotherapy will affect your taste buds, so your taste may become metallic and altered. Again, looking into food items that you've never tried before, sweet, cold, beverages, fresh fruits, salads is very helpful. Try what you have not liked before, and you may see and notice a difference. Moving on to relapse myeloma, the Cheesecake Factory menu with too many options to pick from. Anytime a myeloma patient experiences a relapse, the very first question I usually ask myself and discuss with my patient is that, is it a slow relapse or a fast relapse? Oftentimes, it's slow relapse. We can actually make minor changes, tweaks to chemotherapy, and we can recapture control of myeloma. If we think that myeloma is relapsing quickly or it's a high risk myeloma to begin with, we like to change therapy. We like to change all of the drugs in the therapy. We take into consideration what chemotherapies patients have had before, what side effects they still have, what are their own life preferences and choices they want to make. Are they candidates for newer treatments in the form of antibodies and CAR Ts? Which brings me to CAR T versus a bispecific. I labeled as a Sophie's choice because it's not easy to pick nowadays for between the two options. Little bit about CAR T cell therapy, and just to put some background into it, patients who have had at least 3 different treatments, including treatments in the form of daratumumab and isatuximab that you may have seen, Revlimid, carfilzomib, when they relapse after heavy treatment, their outcomes remain poor with regular run-of-the-mill chemotherapy. We like to consider them strongly for cellular immunotherapy, where you can use drug, antibodies, and CAR T to harness the ability of the immune system to overcome the cancer. And those patients actually tend to do well in a study that we did in a large number of patients. CAR T cell therapy is a form of gene therapy. It's a therapy where we remove your white blood cells from your blood, take them into a lab, introduce a gene into them that makes that beat up, exhausted white blood cell into a super powerful white blood cell that has the ability to actually go back into your body and find cancer where it's hiding and kill it instantly. I like to call it a chimera, which has the head of a lion and a tail of a serpent, and has a unique ability to put myeloma in a deep, long remission. The process is not simple. It requires many multiple steps, and it can easily take 8 weeks or 2 months. after collecting your CAR T before we can give them back into your bloodstream. So it's very important to actually discuss it with your doctor, see a myeloma or CAR T specialist. Some of the important steps include meeting a physician, first of all, getting authorization from insurance, setting up a date to collect your CAR T from your veins. Manufacturing can take anywhere from 4 to 6 weeks. After that, we give some gentle chemo to depress the ability of your immune system from injecting the CAR Ts, and then we infuse the CAR T after that. So it's easily a 2 month period before you can have them back into your body. And early referral and discussion is key. This is a trial that looked at about 130 patients with relapsed myeloma. These patients had a single one-time infusion of a CAR T by the name ide-cel or Abicma. Just to give you a little bit of background, these patients were heavily pre-treated, 6, 7 different treatments given to them before. If you pick any regular run-of-the-mill chemotherapy that is commercially available, on average, 25% of them will have a response. On average, 5% will have a complete response. That response usually lasts for 3 months, and patients who come to the disease in 6 months. We took those patients who were in need of treatment, and effective treatment, and give them a single one-time infusion. 80% responded, 40% went into complete response, and it lasted for nearly a year after a single one-time infusion and no need for maintenance chemotherapy. That is how effective CAR T was. We looked at patients in the real world who may not have been very fit, who had medical comorbidities, who had physical debility, and we realized that CAR T works as well in those patients who may not be fit according to the trial criteria and do not experience any excessive toxicities either. This was another CAR T product known as cilta-cel. We call it Carvykti. It was again studied in patients who were heavily pretreated, did not have good options, and earth-shaking, groundbreaking responses of 98% with 80% complete response. And on average, after a one-time infusion, the patients went on to in remission for 3 years. Remember, these patients had 6 months to live. They got a single time infusion, and a majority of them went on to stay in remission for 3 years. They lived beyond 5, 6, 7 years. So that is why we believe CAR T has really revolutionized the landscape of myeloma treatment. Some of my patients ask me whether I should go with ide-cel or cilta-cel. We call it Bikma and Carvykti, and I give them a very simple answer. If ide-cel is Yahoo, cilta-cel is Google. I think the title speaks for itself. This was a paper that we wrote comparing the two products. But anytime I have a patient who is elderly, who's frail, who I think is beginning to notice some degree of memory issues, I would like to consider option of ide-cel for those patients because of some of the toxicities we have seen with cilta-cel. CAR T was approved for 4 prior lines of therapy 3 years ago. This year it got approved in second-line therapy. Dr. Rajiv is actually doing a trial right now where we are looking at CAR T as a first-line treatment. So I do think that it will creep all the way up in the frontline treatments for myeloma patients. Moving on to bispecific antibodies, these again utilize or harness the ability of the immune system, redirect it towards the cancer and kill it with the cancer. In this particular busy slide, we are showing you 4 different bispecific antibodies that have been studied in trial for myeloma patients with heavily pretreated disease. On average, 70% will have a response. Nearly half of these responses are complete responses, and on average, these responses can last anywhere between 1 to 2 years. Having said that, they do require ongoing treatment, weekly or every other week treatment. They do entail the risk of infections. They need antimicrobials, IVIGs, and inconvenience as well as you have to go to a cancer center frequently. But on the contrary, other hand, CAR T is one and done treatment that does not require ongoing treatment or put you at high risk of infections like the way antibodies do. So take home messages here. Multiple myeloma is the most sensitive at a time of diagnosis towards chemotherapy. Treat it aggressively, treat it early. Your first response is your best response when it comes to myeloma. Your first response should be a complete response. That can be very well achieved with 4 drug combination followed by a transplant if you're eligible for it. As of now, the maintenance is lifelong. I am very hopeful in the next coming few years, we will be stopping maintenance in some of our patients who have achieved a very deep level of remission. Very important to identify some of the complications of myeloma, including bone pain, infection, need for vaccines. Discuss with your physicians. Keep yourself up to date with all the new developments with COVID. Let me go back to the story that I started with. Just to give you a quick refresher, this is a 65-year-old school teacher with relapsed myeloma, 90% myeloma in her bone marrow, very fatigued, very tired. PET CT scan is showing the skeleton is riddled with lesions. She came in to see me for a CAR T referral for a consultation. I discussed, and she said she has a grandbaby on the way. That was her motivation behind going towards the treatment. So she did actually go towards CAR T. She actually ended up becoming the very first CAR T commercial CAR T patient in South Carolina. She did not have a uncomplicated course. She had a high grade fevers, very low blood counts, bloodstream infection. I had to give her a stem cell boost from her previously stored stem cells. She recovered her cell counts. She actually went into a complete remission with a day 30 scan looking clean as compared to the previous scan. I'm usually the physician who works on Christmas. I see a lot of my patients at that time, and I remember after a long day working on December 25th, I came back to my office, opened my mailbox, and this is what I found waiting there for me. She had a newborn, and she was able to hold them in her arms. She went on to live her life with myeloma and eventually succumbed to it, but she was glad that she was able to make it to that memory of her grandchild. This is a group of phenomenal myeloma physicians that I work with. Dr. Rajiv is one of them. We see patients all over New York. I have also worked with some transplant and cell therapy doctors who are part of the group. I'm very grateful to all the people that I have collaborated with for research all over the years, all over US. And with that, I'll come to the end of my presentation. I'm sure we'll have some questions from the audience as well. Thank you.
Thank you so much, Dr. Hashmi. That was quite, a very succinct and fast overview of myeloma, which is no mean feat to do in 25 minutes. And thank you for all the memorable memes as well. I will hold on to questions until for the first panel discussion with you and Dr. Stanchina, and also address questions afterwards in the Q&A section. Thank you, Dr. Hashmi. Now we move on to the next speaker, which is Dr. Michelle Stanchina, who's joining us from the University of Miami, who will be talking to us about some clinical updates in one of the most common lymphomas that patients have, which is diffuse large B-cell lymphoma. Dr. Stanchina, you can take it away.
Okay, thank you so much. Can you see my screen normally? Because I just want to make sure.
You're not in the presenter mode yet, if you want to switch.
Hold on. Slideshow. I only have a slideshow option. Slide. This is the only option I have, I think.
Here, go to display settings at the top. And then switch that to swap presenter view and slideshow.
Okay, now it's good.
Perfect.
Okay, sorry about that. I'm like technologically challenged today. Okay, so I want to apologize. I have a little bit of a cold, so you have to listen to this raspy voice. But so thank you for the introduction. So I'm going to talk about today clinical updates in diffuse large B-cell lymphoma. I do not have any disclosures. So I want to try to cover a few things. One is obviously to go over just a background on diffuse large B-cell lymphoma, give you a little bit of idea of diagnosis and what that means. I want to discuss the POLARIX trial, which is the addition of polatuzumab to frontline chemotherapy. And I would like to briefly discuss some novel therapeutics for the relapse setting. And so in general, what is lymphoma? So lymphoma is a type of blood cancer that affects the lymphatic system, which is part of the body's immune system. Lymphoma is a cancer that starts in the white blood cells that we call lymphocytes. In general, we have B lymphocytes and we have T lymphocytes, which have different regulatory mechanisms in the immune system, and they travel through the lymphatic system as well. The lymphatic system is a network of organs and vessels that helps filter lymph to remove foreign particles and microorganisms. So in general, people often ask, what I don't understand lymphoma, what is lymphoma? And, I try to explain that in your immune system, your body is constantly making new cells. The cells are constantly trying to change on purpose in order to fight different pathogens. And what happens along the way is somewhere along when they were dividing, there was a mistake with the division, and then that mistake just kept dividing over and over. So in general, lymphoma can present in a lot of different ways, depending on exactly what type of lymphoma you have. Some people can actually feel swollen lymph nodes, and that's how they get a diagnosis of lymphoma, or they can visibly see them in their neck or feel them in their groin. Some people can have a lot of fatigue or unexplained weight loss. We usually, not like 1 to 2 pounds, but usually you'll see like 15, 20 pounds weight loss in somebody who's not really trying to lose weight. You can have people present with a lot of infections. They say they're chronically getting sick. Some people have drenching night sweats. Sometimes for women who are in the menopausal range and they're having night sweats already, it becomes a little bit confusing and it delays their actual diagnosis because they're already having these symptoms from menopause. Some people can get rashes. They can be very itchy. They can have high fevers. If you have a lot of abdominal lymph nodes in the stomach or enlargement of the spleen or the liver, you can feel abdominal swelling, abdominal discomfort. And for patients who have large masses in the chest, they can have dizziness, they can feel like they're going to pass out, they can have chest pain, they can have palpitations. Any of these combinations can be a normal presentation. So in general, lymphoma diagnosis, the first thing I always tell my patients is do not Google anything, because there's, over 70 different types of lymphoma. And whenever you Google something, obviously the worst case scenario always pops up first. So whenever I have a new patient with a diagnosis of lymphoma, I think the first thing to do is understand exactly what kind of lymphoma they have. So in general, I think people have heard of Hodgkin's lymphoma versus non-Hodgkin's lymphoma. Basically, Hodgkin's lymphoma is a very specific type of lymphoma, and non-Hodgkin's lymphoma is just a very broad category that includes a lot of different lymphomas. So as I mentioned before, you can have lymphomas that come from the B-cell lymphocytes or the T-cell lymphocytes. The majority of lymphomas are going to be B cells lymphomas versus T cell lymphomas, which are more rare. In terms of both B cell lymphomas and T cell lymphomas, you can have indolent type of lymphomas and you can have aggressive type of lymphomas. In general, when we think about B cell lymphomas, when we think about indolent lymphomas, they don't always require treatment. We usually need a reason to treat them. Either the lymph nodes are very large or the patient's very symptomatic. But we don't usually think of it as something that is curable, other than there are a few nuances to that, obviously. But in general, we think of it sort of more like a chronic disease that is going to have multiple relapses a long time. While aggressive lymphomas are very fast-growing lymphomas, they always require treatment, but our intention is to cure. So obviously, this is not for memorizing or anything, but I just wanted to show you exactly kind of like an example of how many different types of lymphomas you can have. So as I mentioned before, overall, you're going to have more B-cell lymphomas than T-cell lymphomas. We found multiple viral infections that can actually be related to T-cell lymphomas. And you can also see, this is not a comprehensive list at all, but it's just to show you how many different types of lymphomas that there are. So in general, diffuse large B-cell is the most common lymphoma. There's around 80,000 new cases of non-Hodgkin's lymphoma a year, and about 30,000 of them are diffuse large B-cell lymphoma. So to put that into perspective in terms of other cancers like breast cancer or lung cancer or colon cancer, prostate cancer, those cancers have 200 to 300,000 new cases a year. So while diffuse large B-cell is the most common lymphoma, it's still a relatively rare lymphoma. We do know that there's some risk factors for lymphoma. So our patients who are immunocompromised, patients who have HIV, patients who have had a prior organ transplant and are on immunosuppressive therapy, patients who have chronic infection like EBV, HTLV, CMV, EBV, we know that these are can cause lymphomas, and obviously any autoimmune conditions where patients are on long-term immunosuppression. Some of the new drugs that they have in rheumatology Also, their goal of those drugs is to suppress your immune system, and sometimes those have been associated also with lymphoma. One thing that is interesting is that while the incidence of other cancers is actually increasing, the rate of new diagnoses of lymphomas has actually remained relatively stable over time. So after we understand like what kind of lymphoma you have, the most important thing to do is stage the lymphoma. In terms of cancers, I think lymphoma is one of the easiest to understand in terms of staging. The stage 1 is very localized disease. It's just one area of lymph nodes that have lymphoma. Stage 2, you'd have 2 areas, but they're both above the diaphragm. Stage 3, you can have lymph nodes that are above and below the diaphragm. And stage 4 usually involves an organ or bone, or is just widespread disease. What I think is really important for patients to understand is that even if you have a stage 4 lymphoma, it doesn't mean it's not a curable lymphoma. So the staging is very different than a solid tumor cancer, where you in general we think about if it's already spread to multiple organs, we generally think of it as not curable. But I always tell my patients that it's very important to understand that even if your lymphoma has spread, it's still potentially curable. So the other thing that we look at in terms of deciding treatment options for our patients is we look at something called an ECOG performance scale. This helps us sort of determine, the functional status of our patient and the types of therapy that we can give them. Together, when we look at the staging, we look at the ECOG performance status, and we look at age and some lab values, we determine something called an IPI score, or International Prognostic Index, which again helps us just understand a little bit better how aggressive this disease is and how aggressive we can be in treatment options. So one of the most widely used treatment regimens for lymphomas is R-CHOP chemotherapy. So our CHOP itself has been around since the 80s. It's almost been the standard of care since the 80s. We added rituximab I believe in the 90s or early 2000s. And basically this regimen has been the standard of care since then. A lot of different studies, which I'll discuss in the future, have tried to improve upon this regimen, and most of them have been largely unsuccessful. So when we say R-CHOP, it's a combination of chemotherapy and immunotherapy. So rituximab is a type of immunotherapy. It attaches to what we call CD20 markers, which are on the B cells. And it helps activate, your immune system to help fight those lymphoma cells. We also have 3 chemotherapies that are involved called cyclophosphamide, doxorubicin, and vincristine, which all have very distinct toxicities. And we give the patients high-dose steroids. So a lot of times patients can have a lot of symptoms just from the steroid that we give them. This is obviously, you can have some agitation. People get very hungry, which for some of our patients is actually a good thing. And you must be careful, obviously, if you have diabetes, because it can make your sugars very high. So I'm just going to briefly go through this slide, but basically, like I said, there's been multiple attempts to improve on R-CHOP chemotherapy. People have tried to intensify regimens. So normally we give R-CHOP chemotherapy every 3 weeks. They tried to give it every 2 weeks. That did not prove to be successful. They tried to change R-CHOP to a newer version called obinutuzumab. That was not successful. They tried to add drugs, other oral agents that are newer to the regimen, and largely that was also not successful. And they tried to add additional chemotherapies to the regimen, and that did not actually prove to have any benefit for our patients. So this leads us to discuss the POLARIX trial. So the POLARIX trial was another attempt to basically improve upon outcomes for our patients. So it was a phase 3 randomized trial, which randomized patients to either R-CHOP, which was the standard of care, or what we call POLA-R-CHP. So POLA stands for polatuzumab. And basically the way it works is it's an antibody drug conjugate. So is specific. So it is a type of chemotherapy, but it is specific basically for those lymphocytes. So instead of going everywhere in your body, it targets the abnormal B cells. The way it does that is it attaches to the B cell receptor. So you can see there's two parts of the B cell receptor, attaches to CD79B, attaches to that, it is taken into the cell, and then it releases the chemotherapy directly inside the cancer cell. So I like this study for several reasons. One is that the median age was 65. So it did include older patients in the study, which I do think is important because, lymphoma can be diagnosed obviously in our older patients, and we don't want to exclude them from clinical trials. They also included a lot of patients who had advanced disease, so either stage 3 or stage 4, and they included people who had higher IPI scores and higher LDH, which is just a lab value that we can measure with lymphoma. So basically it included patients who had a lot of high-risk features, which I think is important. So overall, the primary endpoint of the study was something we call progression-free survival, which includes progression, relapse, or death from any cause. At the time of the data cutoff in 2021, originally patients had been followed for about 28 months, and the PFS was found to be significantly higher in the patients who got pola-R-CHP over the patients who got the standard of care chemotherapy with R-CHOP. When they did a longer follow-up analysis of over 40 months, they found that the benefit was sustained and that there was an absolute difference of 3-year progression-free survival of 7.7%. One thing that is important about the study is that not everybody benefited. So overall, they did find a benefit, but when they looked a little bit more closely at who benefited, they found that not everybody benefited the same way. So they found that patients that didn't benefit were patients who were 60 years old or younger, which is actually interesting because you would assume that patients who are younger could handle, different drugs a little bit better. Patients with something known as the germinal center B cell type of diffuse large B cell lymphoma also didn't benefit as much. Patients who had bulky disease and patients who had lower IPI scores. So if you look at it, it's really the patients who had, again, some worse features, including higher age, actually did better. In terms of adverse effects, I would say they were pretty similar between the two groups. The most common complication is always peripheral neuropathy. The polatuzumab does cause peripheral neuropathy, and in the R-CHOP, one of the other drugs called vincristine can also cause peripheral neuropathy. And then we saw a lot of side effects that are just very common with chemotherapy overall, like nausea, vomiting, diarrhea, low blood counts, and anemia. This drug was approved in 2023 for adult patients who had previously untreated diffuse large B-cell lymphoma, but only for patients who actually had an IPI score of 2 or higher. So only for those patients in the high-risk group. So why is this trial important? This is the first trial that really shows any significant benefit without increased toxicity over R-CHOP, and it was really practice-changing for many physicians. So when do I personally use R-CHOP? So I only use R-CHOP for patients who have the non-germinal center type, just because in the subgroup analysis, it did not find any benefit in mostly the germinal cell type. And I use it for my older patients who have higher risk features. And overall, they've been doing really well. So this leaves me to discuss some novel therapeutics in the relapse setting. I'm not going to go into any clinical trial specifics. This is just to sort of give you an idea of what is out there. It is certainly not comprehensive. There's a lot of new drugs in lymphoma being developed all of the time, but I just wanted to make you aware of some of the most common things that we do use. So in terms of second line therapy, I know you're going to get a whole lecture on transplant, but transplant is always an option after second line chemo. There's also CAR-T, which I know Dr. Hashmi has already introduced. So he talked about CAR-T in myeloma, but we also use CAR-T in lymphoma. And of course, always clinical trial is always an option. In terms of third line, I'm going to talk a little bit about a drug called loncastuximab. I'm going to talk a little bit about a CAR T. I'm going to talk a little bit about something we call bispecific T cell engagers. And like I said, always keep clinical trials, as options. Okay, so the first drug I want to talk about is called loncastuximab. This drug is also an antibody drug conjugate, so the mechanism of action is very similar to polatuzumab, which I explained before. The difference is that loncastuximab binds to something called CD19, which is a different receptor on the B cell as opposed to CD20. As opposed to CD79B. I apologize. So same thing. It binds on the outside, it is internalized, and then once it's inside the cell, it can release the chemotherapy directly into the B cell. So loncastuximab, again, I'm not going to go over the clinical trials and talk about the efficacy, but it has some very specific side effects that I just wanted to go over briefly. So one thing that's very common is it can cause a lot of fluid retention. So patients can start to see like swelling. Sometimes if the fluid backs up into the lungs, they can start to feel short of breath. A lot of times, if you are on this drug, your doctor also gives you a little bit of steroids, which help to sort of suppress that response. But it is something that we ask our patients to be very mindful of, especially if they notice that they're gaining weight. It's something they should tell their doctor right away. So similar to any other chemotherapy, it can cause low blood counts in the platelets, the red blood cells, the white blood cells. Whenever your white blood cells are down, you can you're at increased risk of any sort of infections. The other thing that loncastuximab can do is actually it can cause a lot of skin reactions. So I've seen patients, especially living in Miami, there's a lot of sun and patients have a lot of darkening of the skin if they go out in the sun. This reaction actually does reverse when you stop the loncastuximab, but we always ask our patients to wear long sleeves when they go outside and wear a lot of sunscreen to make sure that they're not actually getting any burns. So again, I know Dr. Hashmi already sort of introduced the concept of CAR T cell therapy. So I'll just go over it briefly. But basically your T cells are collected from the patient. They are sent to a lab where they are genetically modified, and then they are infused back into the patient. This can take several weeks, as he mentioned, and it can be a barrier to care if patients don't actually live near a specialized CAR T center. There are currently 3 CAR T therapies approved for diffuse large B-cell lymphoma. They all have slightly different indications, but in general, there are 3 options. Something that I would like to talk about is something called bispecific T-cell engagers. So these are kind of the new kid on the block, the new drugs on the block. And I think that we're going to see a lot of these in the future. Again, they are also available in other heme malignancies like leukemia, also myeloma. They have a similar mechanism of action almost to the CAR Ts, but they are what we call an off-the-shelf product, meaning that you don't need to take T cells from your body. You don't need to engineer them. They are available much faster. And actually, I think they have fewer reactions so far. So bispecific T cell engagers are monoclonal antibodies that basically target 2 different antigens. So one targets an antigen on the B cell and one actually targets an antigen on the T cell. So in your normal immune system, your T cells, they help you fight infection, but they can also help you fight the cancer. So the way the bispecific T cell engagers work, they basically bring the T cell in close conjunction to your lymphoma cell, and they help kill that cell directly. So there's currently 2 main bispecific T cell engagers that are approved for diffuse large B cell lymphoma in the relapse setting, and those include epcoritamab and glofitamab. So we can see on the diagram on the right that they both actually have a CD20 arm. So that's the arm that attaches to the B cell, and they have a CD3 arm that attaches to the T cell. The difference is the glofitamab actually has a 2-to-1 ratio of the CD20 to the CD3, while the epcoritamab is a 1-to-1 ratio. Okay. So something that, again, this is a very brief overview. It's not a comprehensive talk, But I just wanted to bring up this one thing that we call cytokine release syndrome. So both for CAR T cells and for the bispecific T cell engagers, one of the most common complications is something we call cytokine release syndrome. The way I explain it to my patients is that we're trying to activate your immune system to fight your cancer. Sometimes your immune system gets overreacted, and then you can have something called cytokine release syndrome, where these molecules called cytokines are released into your blood that can cause things like fever, shaking, chills. In the rare case that happens, sometimes we have to give another medication to sort of suppress that reaction a little bit. So in general, just to summarize, we talked about how to diagnose lymphoma. We talked about current common signs and symptoms. We talked about how to categorize lymphoma, how to stage lymphoma. We talked about standard frontline therapy, including RCHOP. We talked about the POLARIX trial, which was practice changing for many providers in the first line setting. And then we briefly talked about several drugs in the relapse setting, including loncastuximab, CAR T, and bispecific T cell engagers. So I thank you for giving me the opportunity to speak today, and I welcome any questions during the Q&A.
Absolutely. Thank you, Dr. Senchina, for that really comprehensive overview of diffuse large B-cell lymphoma. As a reminder, any patient questions that are coming in are actively being recorded by our GRACE group, and we will be addressing them in the Q&A. But I just wanted to have this brief moment to debrief with both Dr. Hashmi and Dr. Senchina about the two talks they've given. Dr. Hashmi, thank you again for that overview of myeloma. Just a quick question as a treating myeloma physician, a lot of our patient panel tends to be typically patients with precursor diseases, right? And I'm sure that a lot of questions that you keep getting are, what can I do about it? This is really torture, being stuck in limbo. Is there anything I can do? And my question specifically to you is, for those patients who are in smoldering myeloma, who we think are on the verge of really, converting, how have you structured your practice? We have a lot of data coming in which, potentially we can treat high risk smoldering myeloma, etc. But how do you go about it? Are you worried that you're using up some of the agents earlier, inducing therefore resistance to that in what would be typically frontline myeloma? Or just for the audience, how would you go about treating high risk smoldering myeloma specifically? Because that's a question I'm sure which is uppermost on a lot of patients' minds.
Yeah, I think it's a very relevant question, and thanks for asking. When we look at smoldering myeloma, there are at least 3 different models that we can utilize to stratify that into 3 subgroups. Low-risk smoldering myeloma, where the risk of progression to symptomatic myeloma is very low and observation is very appropriate. Intermediate risk smoldering myeloma, where again the risk of progression is a little bit higher than the low risk, but lower than the high risk, where observation is actually what many physicians and practices in the US would do. When the question comes to high-risk myeloma, and different models that have looked at it, looking at the protein levels, the light chain levels, the amount of cancer in the bone marrow, I think one of the very first things that I always do is to, first of all, confirm that it's not already myeloma. I do bone marrow biopsies, PET scans, and MRIs. And once I've confirmed that it is smoldering and it's high risk, I actually discuss it with my patients, because there are certain trials that have shown some benefit of treatment in the form of chemotherapy, oral chemotherapy for a 2-year duration, where they may slow down the progression of the smoldering myeloma to symptomatic myeloma, but not necessarily make these patients live longer. Chemotherapy does come in with some side effects, and those side effects can actually impact the quality of life. I have a robust discussion with my patient, and if they are actually inclined towards having treatment for a high-risk smoldering myeloma situation, I would consider oral chemotherapy options for them. Before I do that, also look into our clinical trial portfolio. Being a major academic center, we have many different clinical trials that are evaluating therapies for patients. And again, if patients have the ability, the desire, the determination to pursue a trial, that will actually be something that I highly encourage all of my patients. Besides, clinical trial, regular therapy, observation, in my opinion, is what I tend to favor, and many of my patients also agree with it, with a very clear plan to follow it very closely. I'm actually doing blood work sometimes every 3 months. There are patients that actually do blood work every month to capture any smoldering from becoming a myeloma in a timely fashion. And I also do scans in these patients periodically, at least once a year. So all of these options I discuss with my patients, and we make a decision in consensus whether they want to go for a trial, whether they want to have some oral chemotherapy options, or they want to actually just observe, but observe very closely. So these are the things we look into.
No, wonderful. Thank you. That reflects a lot of our practice as well, but that keeps getting, second opinion consultations, etc., when they hear the same opinions from other doctors as well. So thank you for clarifying that. Dr. Sanchina, you talked a lot about diffuse large B-cell lymphoma, and just one question that, again, usually comes up in diffuse large B-cell lymphoma. There's been a lot of new data that's been coming, and you talked about the POLARIX trial, right? And there has also been new kids on the block, such as brentuximab and nivolumab really being tested out in this setting as well. So how have you taken this data and really going ahead with treating patients at the frontline, newly diagnosed diffuse large B-cell lymphoma stage? Do you always now revert to polatuzumab as your option, or are there instances in which you would go for brentuximab, nivolumab, or just, fall back to plain old R-CHOP, which has stood the test of time for 40 years?
Yeah, so I think a lot of things obviously are rapidly changing. I think in the frontline setting, for the most part, your options are still sort of chemotherapy based, to be honest. There are good clinical trials as well for patients in the frontline setting. So recently there was a clinical trial that was open through Dana-Farber that was also open at our institution. It actually included Polar chip in the first line setting for all patients, whether they were GCB or non-GCB, and it included a bispecific T-cell engager in the front line. Again, this was only for patients who had very aggressive disease. But, obviously that we finished enrolling here. All my patients have done really well. I don't know, I obviously don't have the data or the results of any of the full trial, but I think you're going to start to see more bispecific engagers, to be honest, being used earlier on. Just because, like I said, it is much easier to use a bispecific than do CAR T-cell. I think the order of things is very complicated, and it likely will not have studies, that they're going to confirm exactly what the correct order of treatment is. But for the most part, if a patient is not on a clinical trial, standard chemotherapy is basically still your frontline option.
Sounds great. Thank you so much. And with that, I think, to catch up for time and keep this session on track, we can proceed on to the next section, which is talking about BMT and leukemia. Thank you, Dr. Hashmi and Dr. Sanchina. So next up is Dr. Muhammad Salman Faisal. He will be talking to us about introducing basics of bone marrow transplantation, what patients need to know, and how do clinicians go about it. So, Dr. Faisal, the floor is yours.
All right, thank you so much, Dr. Rajivi, for having me, and thank you everyone who is listening on a Saturday morning. And we're going to quickly talk about the stem cell transplant and a little bit about cellular therapies. I'm a myeloma and transplant physician at Oklahoma University Jefferson Cancer Center. So first of all, I didn't put a disclosure slide, but I do not have any disclosures. The objectives of today's talks are to quickly run over a little bit history of transplant, discuss autologous and allogeneic transplant, which are the most common two types of transplants, and talk a little bit about toxicities. So autologous transplant is when you get your own cells reinfused after systemic therapies that are given. An allogeneic transplant is where you get a transplant from a well-matched, healthy donor, and it is kind of divided into who is the donor. It could be your sibling, it could be someone from a registry, it could be someone who is half matched. And in past, we used to do a lot of cord blood from umbilical cords of fetuses, but that has dropped down in the recent times. The history of transplant. So the transplant started back in 1950s after the World War and the fear of and the effects that we saw after the large exposure of radiation in the big Japanese cities. After that, they start working on finding a ways to rescue those people. The first transplant that was done was back in 1959. And initial few years were not a success. Later, slowly, we started to understand better about the HLA system in 1971 and the effects of matching the HLA system, and that made us do transplants in leukemia patients, and they started surviving better. In 1990, Dr. Thomas from Washington University, he won the Nobel Prize for this discovery. And in the more recent times, we are doing way better in our transplant patients compared to what we were doing about 20 years ago, because we have better supportive care and better understanding of how we can make the transplant less toxic. So talk about a few things. These are the 2020 data on use of autologous and allogenic stem cell transplants. So you can see the use of transplant is increasing. We see a little, we see use was increased in 1990s for autologous transplant. This was done on the basis of a small trial for breast cancer, where we gave the patients a lot of chemotherapy and then gave them autologous transplant. Unfortunately, in 2000, we proved that this didn't work, and then this curve dropped. So we need to be sure about what we are doing before we make a big change. So this was a big lesson in the history of transplant, that we should not be doing transplants indiscriminately. Most of the transplants are done for the most of autologous transplants are done for multiple myeloma and non-Hodgkin lymphoma, and most of allogenic transplants are either done for AML or MDS. So autologous transplant is just high-dose chemotherapy, which is so high dose that it kills off a lot of cancer cells and also puts the bone marrow in aplasia or hypoplasia. And the idea is to put the stem cells from the same person collected before doing that to the patient, and getting rid of the disease and rescuing their bone marrow. Patient has to be chemosensitive to this high dose of chemotherapy before doing all this. Again, as I said, we use it mostly for multiple myeloma and non-Hodgkin lymphoma. Dr. Hashmi did an excellent presentation on why multiple myeloma autologous transplant is still the winner despite having so many new options. For autologous transplant, a few things to consider. One, the patient has to be sensitive to chemotherapy. So we give them chemotherapy to control the disease, and that also tells us if doing autologous transplant will be a good idea. The conditioning is something called myeloablative, very high dose chemotherapy, usually involving high dose alkylating agents. We do a combination of chemotherapy with what we call BEAM in Hodgkin or non-Hodgkin lymphoma, and high-dose melphalan in multiple myeloma. Some data behind why we use that. So in patients who had relapsed large B-cell lymphoma, this CORAL trial was done back in 1990s, early 2000s, and it showed that about 50% of patients can be cured by doing a autologous stem cell transplant after high-dose chemo. And for multiple myeloma, determination study is a very recent study which compared transplant to doing a combination of 3 drugs alone, and it showed that the progression-free survival, which is the time from transplant to the disease progression, improves with transplant. It did not improve the overall survival because we have so many good options to treat multiple myeloma patients, and the follow-up, despite being 7 years, is still shorter for that. So in comparison, the autologous allogenic stem cell transplant is where you use a graft, a donor for stem cell transplant. And the principles of allogenic stem cell transplant are, number one, having a donor which is healthy enough to donate and they do not have any disease. Could be a related person, a sibling, or an unrelated person from a NMDP registry. And I encourage everyone who is listening, if they are healthy, to consider enrolling on NMDP registry for being a donor for stem cell transplant. It is free and it's a great service to humanity. The cancer control in allogenic transplant, in autologous transplant, it was only chemotherapy, high dose chemotherapy. In allogenic transplant, you do immune mediated cancer control as well by something called GVL, or graft versus leukemia effect, in which the graft you put in from the transplant actually surveils and finds the cancer cells and kills them. And that's the principle of allogenic transplant, and that's what makes it the most primitive form of immunotherapy. All the new immunotherapies that we're doing, CAR-T or T-cell, tumor-infiltrating lymphocytes, all that is kind of a new version of the old immunotherapy, which is allogenic stem cell transplant. As I said, allogenic transplant is very dynamic. This graft that we give works as a new organ, a new transplant, and it helps us to fight the cancer cells. And then all the graft versus leukemia effect that we get from these transplanted cells, transplanters, allogenic transplant, helps us fight cancer, but at the same time, it can produce something called a graft versus host disease, which is what is the biggest comorbidity or biggest problem of doing allogenic stem cell transplants. If you have high GVHD, you have high chances of graft versus leukemia effect. So we want to get somewhere in between where we have a lot of graft versus leukemia effect and very little graft versus host disease. Some evidence if the allo transplant does work, so it does. We have big CIBMTR studies which host the largest data of allogenic as well as autologous transplants, and we see that the probability of patients being alive at 5 years from AML in the cohort of patients that were transplanted between 2008 to 2018, the patients who had transplant in their first remission had about 60% survival compared to the patient who never had a CR or relapsed after that. They had the worst survival. And that is also true for acute lymphoblastic leukemia, for aplastic anemia, which is not a malignant disease, which is not a cancer, rather an immunological disease. Transplant outcomes are way better because we do not need to have that graft versus leukemia effect, so we manage it a bit differently. And then with time, with each passing decade, we are doing better on doing an allogenic stem cell transplant, and our patients are living longer with that. So some requirements about successful allogenic transplant. Number one, to have appropriate disease indication. Allogenic transplant, unfortunately, is a very toxic treatment. And when I do allo transplant consult, these are the few things that I discuss with my patient in a long detail on the first consult as well as in subsequent encounters. The major indication for an allo transplant at this point in 2024 is either acute myeloid leukemia with adverse or intermediate risk characteristics, or myelodysplastic syndrome. And for other diseases like non-Hodgkin lymphoma or Hodgkin lymphoma or multiple myeloma, allogenic transplant is very rarely used. In pediatrics and in young adults, aplastic anemia is also an important indication. Availability of suitable donor. So about 20 years ago, our major donor source was a sibling who had complete HLA match. HLA is a special typing that is done on white cells. So that was our major donor source. Now, in last 20 years, we have expanded our donor source to unrelated donors a lot. We have gotten better doing HLA matching, and we have a registry of about 30 million people in US as well as around the world. Uh, if you are a white American, you have about 77% chance of finding a unrelated donor in that registry. But unfortunately, if you're one of the minorities, your chances of having a donor fall down to like 20 to 25%. So if you do not have an unrelated matched donor and you do not have a sibling, those patients about 20 years ago only had a cord blood donor option, which was also not very good. So a lot of patients did not have a good donor options. But with arrival of something called an haplotransplant, which is also a sibling who is a half match or a parent or offspring who they always have a half match to the patient or the index case. So that has expanded our donation options a lot. So the disease and the host should be in optimal state for transplant. If your disease is completely controlled, you have much better chance of doing well with transplant compared if you have active disease. With the host characteristics, like we need to make sure that the patient is healthy enough to do the transplant. So having good heart function, good lung function, good liver function, kidney functions, these are all things that are tested before transplant to make sure that we get the patient to do the transplant only if they are fit enough, because we have found over time in a lot of studies that if we do transplant in patients who have suboptimal organ functions, they do even worse than not doing transplant. So in those situations, we tend to avoid this toxic treatment. Conditioning regimens are the preparative chemotherapies. So we do it based on the patient disease and other characteristics. GVHD is a form of problem that happen with allogenic transplant, in which the donor cells that come from the graft, they attack the patient's organs, and we do prophylaxis with immune suppression during the beginning of transplant, and we give a very aggressive supportive care especially in the first 100 days with antibiotics, blood transfusions, keeping a good control of the environment, vaccines, and everything. And then long-term follow-up and survivorship is important for allogenic transplant. Kind of went over the indications. AML and MDS, MPN are the major indications for allotransplant. Donor selection. Few things about donor selection. Sibling donor is still better than unrelated donor, and unrelated donor and haplodonor are kind of equivalent, especially with the new things that came in the transplant world. Younger donor is better. Male donor is better than a female who has been pregnant, because pregnancy gives a lot of antibodies to females. Infection status is important. ABO type is semi-important, and overall health of donor should be good. Histocompatibility or HLA matching, which is a special sort of white cell typing, is a prerequisite for doing a good transplant. So kind of go over these things. These are the trends of how donors have been selected over time. So if you see, this blue curve is the matched sibling donor. So historically, the biggest source of bone marrow donation or stem cell transplant donation was a matched sibling donor in Around mid 2005, the unrelated donor picked off, and it is the biggest source. And now in 2019, the other relatives of, or most likely half matched donors, is meeting the match related donor options. This is probably because we are doing a lot more transplants than we were doing back in 1990s, because if you do not have a sibling donor, then your options were very, very limited. As I said, disease control should be optimal. We like patients to be in complete disease control before transplant, but if that cannot be achieved, minimal disease state is important, and then the host or the recipient should be young with minimal comorbidities. This is a score which is called hematopoietic stem cell transplant disease index, or comorbidity index score, that was developed back in 2005, and it has different risk factors that are given based on a training and a training cohort and a confirmation cohort. And we found that if patients have higher risk factor of diseases, they have worsen outcome with the transplant. So if someone is having really bad liver, lung, or heart disease, that's why we don't even do transplant on those patients. Conditioning is what sort of chemotherapy the patients get before transplant. So you get a myeloablative, which is a strong chemotherapy, or a reduced intensity conditioning. What I do is I prefer myeloablative conditioning if the patient can tolerate, but if they cannot, then reduced intensity or non-myeloablative conditioning is pretty good option as well, with the caveat that the chances of disease coming back are higher with the reduced intensity conditioning. Some common regimens for graft versus host disease prophylaxis. This is something our patients listen a lot, especially when they have when they're undergoing the allogenic stem cell transplant. We have different types of regimen. The thing that came out very recently is called post-transplant cyclophosphamide, and this has definitely revolutionized the care of these patients, because the long-term graft versus host disease or chronic graft versus host disease has decreased a lot with post-transplant cyclophosphamide use. Supportive care, very, very important. The main reason the patients are living longer and better after allogenic stem cell transplants. You do transfusions, you give a lot of nutritional support, infection control, extremely important, antibiotic prophylaxis, precautions, environment control, and if there is any fever or anything, aggressive management. Treatment of other toxicities, growth factors, strength and conditioning, especially in the elderly, is extremely important for these patients, especially in the after transplant in the first 30 to 100 days. And then keeping an eye on what medicines they are taking, so you reduce the exposure to multiple medications, and that way improve the outcomes of the patients. For after transplant, I get my patients back once. I keep them in hospital for about 30 days till their white cell counts recover. After that, I get them back twice a week in my clinic for another 30 days, and then and start doing once a week after that till about 6 months, and then we slow down after that if there are no complications. We monitor very carefully for toxicities during those visits. We talk about, we restage the disease multiple times, make sure the disease is not coming back, and then taper the immune suppression if they don't have graft versus host disease. Start doing the baby vaccines again, especially focusing on the big childhood sort of diseases and hepatitis B, pneumonia. These vaccines are extremely important. COVID vaccine is extremely important. Flu vaccine is as well. So all these vaccines are done about 3 to 6 months out of allogenic transplant. And if the patients are relapse free at 1 year, and So that always is a very important time mark. If the patients live till 2 years without disease, their chances of making to 10 years becomes about 85%, which is amazing. So toxicities, infections is the number one. When we give that much of chemotherapy, the immune system kind of reduces to zero. On our units, we don't have to put patients in those like airbags or like no visitation like that, but we definitely have to control the environment. We have to watch out for infections very, very carefully. We monitor for different viral activations. We give antivirals, antibacterials, antifungals, and if there is any concern for infection, we go very aggressively about treatment right away. Graft versus host disease, which is, as you remember, it's a disease that happens, or it's a complication that happens when the donor cells start affecting the recipient organs. So it comes in two forms. Acute forms affect liver, GI tract, and skin. So it can be really bad rash, diarrhea, or liver problems. Used to happen about 30 to 50% of cases with the post-transplant cyclophosphamide. Its incidence is slightly lower now. Severity has definitely become better. Happens within first 100 days, and then it's a clinical diagnosis, and it can come in different forms: skin rash, GI tract abnormalities. We have different scoring systems for that. Treated with steroids, or second line treatment is something called ruxolitinib, which is another immune suppression. Chronic graft versus host disease used to be a big problem again with the it affects up to 30 if affects 30 to 70% of patients in different form of severities. Again, with post-transplant cyclophosphamide, the incidence is becoming less. And then it is kind of like chronic autoimmune disease, more like lupus or multi-system connective tissue disease sort of diseases. And can affect various different organs, and very difficult, very problematic to treat when it happens. So that's why these new immune suppressions that are coming are great, that they're decreasing the incidence of this disease. So just like any connective tissue disease, it can affect any organ: skin, eyes, GI tract, nails, lung and liver are the big problems, and they used to be the real cause of death in patients after transplant due to chronic GVHD. Again, treated with steroids, ibrutinib, and there is a new drug, belmucidil, that are working really well against these chronic complications. Lung toxicities are important. Other toxicities, especially during hospital admissions, are important, which include malnutrition, mucositis, a special sort of liver disease called veno-occlusive disease, transplant-associated microangiopathy, cardiac disease, and then a whole lot of long-term complications that we watch out for. As I said, if the patients live at 2 years in a big CIBMTS studies, 10-year survival was 85%. The problems that happen after transplant, acute GVHD, or the disease relapse or infection, these are the three big reasons of patients not doing well, unfortunately. But once we have control of these things, then we have patients in clinic that live for many, many years, but still we have to watch them for any secondary complications or other problems. I did put a little section on adaptive cellular therapies, which include CAR-T. So these are a few cellular therapies that have come up in last few years. So donor lymphocyte infusion is an extension of stem cell transplant in patients who have received a transplant and have some disease relapse. So we essentially get the lymphocytes from the donor and give it back to the recipient to control the disease. Lymphocyte activated T cells. So we get the T cells from the cancer patient, and put interleukin-2 and then enrich the cells and give it back to the patients. Tumor infiltrating lymphocytes are for solid cancer patients, in which we resect the cancer, remove the T cells from the cancer itself, and enrich and expand and give it to the patients. T cell receptor technology, which the prime examples of these things are CAR T therapies, in which we get the T cells and put a special and engineer them to put a special receptor on them and then put it back to the recipient. Most cellular therapies work in a way that you get the cells, you get them into the lab and put special activators or transducers and then put the cancer cells back after a little bit of chemotherapy. And then these are the FDA-approved CAR T products that are available for B-cell lymphoma as well as multiple myeloma. The blue ones are for multiple myeloma. The red ones are for B-cell lymphoma. The gene therapies are another exciting avenue in the world of adaptive cellular therapies. So these gene therapies get the the cells from the stem cells from the patient themselves and put special normal genes and then infuse those stem cells back to the patient after a high dose chemotherapy, just like a myeloablative chemotherapy that we talked about for stem cell transplant. So it's a form of an autologous stem cell treatment after doing special modification on the genes of these patients because they have abnormal genes. So we are using them against sickle cell, we are using them against hemophilia and beta thalassemia patients. And the outcomes for these all these gene therapies in a short-term follow-up are pretty good. And then finally, we have a tumor infiltrating lymphocyte approved for relapse refractory malignant melanoma, which is a skin cancer. And we do what we talked in a couple of slides ago. We resect this cancer, get those T cells from the cancer, and then infuse those T cells into the patient who has metastatic disease to keep the other sides of cancer under control. The toxicities with the CAR Ts are usually what we call CRS, which is a really bad flu-like syndrome, and a neurotoxicity, which is a constellation of symptoms, including going from confusion to deep coma, and we watch for that very carefully. And then other side effects are infection, cytopenias, and low B cells, especially for against in the non-Hodgkin lymphoma CAR Ts. Delayed onset neurotoxicities and other neurological effects are being seen with the new products as well. CRS is a multi-system a problem that usually presents with fever, shortness of breath, or low blood pressure, but can involve a lot of other organs at the same time. And then mechanism of CRS is increased release of different cytokines in the blood, and mechanism of ICANS is the CAR T cells going into the crossing the blood-brain barrier, going into the brain and producing all those cytokines. Again, gene therapies, we talked a little bit about it, but this is one of the trials from sickle cell disease patients, and we have the longest follow-up on a patient up to 48 months, and they are doing well without having a lot of side effects. It doesn't cure them completely, but it definitely improves their quality of life. And with that, I will like to thank you all, and I will be happy to answer any questions during our panel discussion. And special thanks to Dr. Al-Juhaishi, who helped me with the slides.
Wonderful. Thank you so much, Dr. Faisal. That was really, really comprehensive, and it's no mean feat again to condense a lot of bone marrow transplant into this short talk. So we will be circling back for the panel discussion and for the Q&A. It's now time for Dr. Srisivana Newcorn, who will be talking about frontline therapies for myelofibrosis, which again is part of the whole blood cancer is known as leukemia. So Dr. Srisula Newcorn, you can take it away. You might want to unmute.
Sorry. Can you hear me now? Yeah.
Yes, we can.
Thank you so much, everybody. Good afternoon, and thank you for your patience. I apologize for the technical difficulties I had this morning. Even though I'm an AI researcher, even I can't get Zoom to work consistently. So my name is Andrew Newcorn, and I'm a physician at Ohio State University at the James Cancer Hospital in the section of leukemia. And my clinical focus is a niche chronic blood cancer within the realm of myeloproliferative neoplasms. And these diseases are chronic diseases that patients can live with for years to even decades. And I'm happy to talk to you about my approach for one of the myeloproliferative neoplasms called myelofibrosis. Now, I understand these diseases are quite rare, and likely a lot of you have never even heard of this disease before, and that's okay. I'll be starting with the basics. So for today's talk, I'll be talking about a general overview of all the myeloproliferative neoplasms in regards to their biology and epidemiology. I'll furthermore go with a case presentation and give practical management points and give a couple paradigms about how other experts and myself think about upfront treatment for myelofibrosis. And finally, I'll be giving a brief overview about what we're excited for and the next generation of novel therapeutics in this disease space. So first, a general overview of these diseases. The myeloproliferative neoplasms. Now, the first disclosure is that CML, or chronic myeloid leukemia, technically is one of the myeloproliferative neoplasms, but the biology is so significantly different that I will not be talking about CML today. Instead, I'll be talking about the other classical myeloproliferative neoplasms, including polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Now, these three diseases are all related, and they have different phenotypes. Polycythemia vera, or PV, typically a patient has elevated red blood cells. And in essential thrombocythemia, or ET, patients have elevated platelets. Now, myelofibrosis is a little bit different. Patients tend to be very symptomatic, which I'll go into, and patients actually have low blood counts, low hemoglobin, low platelets. But the reason why these are all related is because they have the same pathophysiology behind it, with the same driver that's causing these diseases to exist. I'll be talking specifically about JAK2, MPL, and CALR, but they all have the same underlying biology. Now, to make a very important point, because I understand that these diseases are all very confusing, you may have heard of certain types of acute myeloid leukemias, or AML, or other conditions like myelodysplastic syndrome, or MDS, but MPNs are not that. So unlike MDS and certain AMLs where their counts are low, MPNs, the P meaning proliferative, the cell counts are actually very high. And I want to highlight that point again with this paradigm that I've created, because these diseases are confused each other all the time. And as I mentioned, myelodysplastic syndrome, the D, dysplastic, means things don't work. You have ineffective red blood cell and platelet production. And these patients with MDS, they have low blood counts, low hemoglobin, low platelets. Completely contrast that with what I'm talking about today, myeloproliferative neoplasms. The P meaning proliferative, things are high. There's mature cell overproduction with increased red blood cells and increased platelets. Now, it is true that I'll be talking about these diseases might change, and there might be a lot of scar tissue from these diseases that leads to low red blood cells and low platelets. So there is a transformation that kind of looks like MDS, and even more confusing is a third completely separate category called MDS-MPN overlap syndromes that have features of both conditions where their blood counts are low and high at the same time. And these three conditions or families are different. Commonly, they all can progress to a secondary form of acute myeloid leukemia, but that's kind of where the similarities stop. So as a brief reminder for today, I'm not going to be talking about the left two. I'm not talking about MDS or MDS-MPN overlaps. I wanted to focus on the myeloproliferative neoplasms, specifically one called myelofibrosis. So epidemiology amongst these three diseases of PV, ET, and myelofibrosis, these are rare chronic blood conditions at a rate of 3 to 11 per million person years. And as you can see on the bottom left, it tends to be a disease with the age of onset is later in life, with peak incidence at around age 80, as highlighted by that vertical line that I've created. On the right side is the rarity or the incidence across the decades, 2000 to 2012. And you'll see that across these diseases, myelofibrosis is the most rare at about 3 cases per million person years. So the etiology of the MPNs, I do have to talk a little bit about the biology because it'll make sense why we treat the MPNs and what types of therapies we do. So as I mentioned before, the biology is the same across these three. There's a mutation in the DNA from these patients that is acquired at some point in their lives. And this mutation is commonly called JAK2 or CALR or MPL. And I make the analogy of a light switch to my patients. Imagine you have a regular healthy person that can make the red blood cells and they can make the platelets. But at a certain point, we can stop making red blood cells and we can stop making platelets. But that's not really what happens in myeloproliferative neoplasms. Because of this JAK2 mutation, I make the analogy that the light switch is always on. The red blood cells keep being made and they have a really big difficulty stopping it. So what has happened is what we call activation constitutively of this really important pathway called JAK-STAT, where things continually be made in a realm called inflammation or a lot of activity. So specifically, this JAK2 mutation lies on a lot of important receptors on the patient's stem cells. EPO on the left, TPO on the middle, and GCSF on the right. And what happens is that once the JAK2 mutation is kind of in the always on position, when the EPO receptor is activated, you get quite a lot of red blood cells. When the thrombopoietin receptor is activated, the middle one called MPL, you get a lot of platelets. And similarly on the right side, when the GCSF receptor is activated, you will get a lot of white blood cells as well too. So the genotype, meaning the mutations of JAK2, they lead to the phenotype, meaning how the patients present with all the increased production of all these blood cells. But as I mentioned, when the factory is always on, the lights are always on, there's quite a bit of inflammation, and that leads to a lot of scar tissue in the factory of the blood cells, and that's called the bone marrow. So when there's a lot of scar tissue or fibrosis, what happens is that there's not a lot of space for the blood cells to be made anymore, and you become anemic with low red blood cells or thrombocytopenic or low platelets. So the disease can transform with the constant activity from this disease, from the mutations. One important point that I always talk about with my patients is that these mutations are acquired at some point in their life. They're not inherited from their parents. So the natural history of these diseases, ET and PV, I think of more the early forms of these diseases with increased red blood cells and increased platelets. These diseases can progress across 2 different axes. Number one, as I mentioned before, with the ongoing activity, scar tissue can really develop, as you can see on this left side of the patient's bone marrow biopsies, with the scar tissue or fibrosis highlighted by those fibrotic networks in dark blue. With ongoing activity in time, you can see that the scar tissue develops further and further, and the disease transforms to either a secondary myelofibrosis, or patients can be diagnosed at that time, and that's called primary myelofibrosis. When we get to the myelofibrosis stage, you can acquire many more mutations outside of JAK2, CALR, and MPL, and that leads to a lot of instability, also leading to another condition called acute myeloid leukemia or blast phase myeloproliferative neoplasms. That's a condition that's very, very challenging to treat. And soberingly, we don't have any therapies in 2024 that really meaningfully prevents progression in either of these axes for fibrosis accumulation or for progression to acute leukemia. So key takeaways from my brief overview are that MPNs are rare cancers. They're diagnosed late in life. The phenotype includes the elevated blood counts. There are many symptoms that I'll be talking about that's due to inflammation. The main mutations are JAK2, CALR, and MPL. And the main outcomes that I wasn't able to talk about out of brevity of time are blood clots and progression to acute leukemia. So moving forward to today's focus, I'm going to give a case presentation for a patient with myelofibrosis. Now, this is a 58-year-old that previously had polycythemia vera with a lot of red blood cells for many years, 6 years, and they were doing great. But recently, they had new symptoms, including weight loss, night sweats, and abdominal pain with difficulty finishing their meals. On physical exam, we were able to palpate their spleen on the left side of the abdomen at very large, 20 centimeters below the left costal margin of the ribs. Their blood counts showed that they have a new anemia with a hemoglobin 9.9 and a new thrombocytopenia with platelets in 76. Again, we found the JAK2 mutation, and the gold standard to figure out what's going on at this point is a bone marrow biopsy. And with that, we diagnosed the patient with post-PV myelofibrosis. So myelofibrosis, the main diagnostic criteria, as I mentioned, includes a couple things. Number one, bone marrow biopsies are key and very, very necessary. We would give a patient's bone marrow biopsy to a hematopathologist to expertly look under a microscope for key features, including atypical or abnormal features within a very specific cell called a megakaryocyte. That's number one. We also want to see if they have a lot of this network for fibrosis, with grade 2 and 3 being the largest amount of fibrosis. That's the first major criteria. And as I mentioned before, we need to find the JAK2, CALR, or MPL mutation, and we want to make sure that they don't have any other blood cancers such as CML or acute leukemia. So how do patients present? I briefly alluded to it in the case presentation, but patients typically have quite large spleens, and that causes the majority of the symptoms. Patients can have abdominal pain, bloating, and fullness that leads to early satiety where they can't finish their meals. They can have portal hypertension and acute pain in their left side due to infarction from the spleen because it's growing so rapidly. Due to the fibrosis buildup in their bone marrow biopsy, they would see that there's not enough room for blood cells to be made, and they would have low platelets and low hemoglobin and maybe even low white blood cells. Due to the ongoing activation of the pathway that's important, there's cytokines that are released and a lot of inflammation. And patients present that with fatigue, night sweats, weight loss, and even bone pain. So moving forward, with these symptomatic patients, how do I choose the frontline therapies? So just as a brief timeline, we are in a golden age for therapies in myelofibrosis and MPNs. I mentioned the activation of the JAK-STAT pathway as kind of an analogy of a light switch. And we have all these therapies collectively known as JAK inhibitors that can turn off this light switch. There are 4 main JAK inhibitors nowadays that are approved in the past decade or so, mainly ruxolitinib, fedratinib, pacritinib, and momelotinib that can do exactly that. Now, how they work, they inhibit a couple different receptors on the patient's malignant cells that are really important, including JAK1, JAK2, and ACVR1. JAK1 and JAK2, as they're signaled downstream into the DNA, they use the JAK-STAT pathway that I mentioned is the most important part of MPNs. But for myeloproliferative neoplasms, inhibiting this one on the right side, the JAK2, is the most important. You may hear about JAK1 inhibitors in other autoimmune conditions such as psoriasis and lupus. And there's a third pathway using a receptor called ACVR1 that we've learned is actually very helpful for a couple of the myelofibrosis patients. So we've learned that for some of these medications that are newer, called pacritinib and momelotinib, inhibiting ACVR1 actually has a side benefit, and then it corrects anemia in certain conditions, particularly myelofibrosis. So all four of these JAK inhibitors have different levels of inhibiting JAK1, JAK2, ACVR1, amongst other receptors. And that leads to some of the niche nuances about how these JAK inhibitors can be helpful for the upfront setting in myelofibrosis. There are many different paradigms to think about how to start a therapy, but here are just a couple. There are many different risk stratification systems that I'm not going to be talking about, but some of these risk stratification systems include looking at patients' blood counts, symptoms, presence of leukemia cells called blasts, and presence of adverse mutations and chromosomal issues. We can risk stratify generally into lower risk and higher risk patients. And therefore, we can think about how we treat the patients. Now, one specific point that warrants calling out is that these JAK inhibitors are very, very good at shrinking patients' spleens and reducing their symptoms. But soberingly, they don't change the big picture. They don't really delay the progression to acute myeloid leukemia, and that would have happened regardless of if we started a JAK inhibitor or not. And that leads me to that first point. For asymptomatic patients, I'm very comfortable to not start any therapy and just observe them, because the majority of my decision making for patients is largely driven by patients' quality of life and goals. So, moving forward, there are other paradigms that other disease experts, such as Dr. Ferry at the Mayo Clinic, have relayed. But at a high level, I just provided the summary on the right side. Most patients with symptomatic splenomegaly with a large spleen, up front, they're going to get the first one, ruxolitinib. And if the ruxolitinib is not working, typically we switch to another one called fedratinib. But with the novel JAK inhibitors in the past 2 years with very specific niche nuances, very helpful in the thrombocytopenic patients, pacritinib, and very helpful in the anemic patients is momelotinib. And that leads us to a very personalized, very complicated regimen of a lot of JAK inhibitors that we can reach for in our bag of tricks. So the clinical takeaways is that the therapies are targeted mostly to alleviate symptoms in myelofibrosis, including shrinking the spleen, amongst the other B symptoms of fevers and night sweats. Each JAK inhibitor has nuanced indications, particularly with thrombocytopenic patients and anemic patients. But as I mentioned soberingly, that there's no current therapy that prevents progression to acute leukemia. But where are we going and what are we excited for? At a high level, there are so many different pathways outside of the critical JAK-STAT pathway that we as the scientific community are exploring. And there are three main takeaways. Number one, we're looking at so many different drugs in pathways that don't exist in JAK-STAT pathways. But number two, maybe we can do better by combining novel therapies along with a JAK inhibitor such as ruxolitinib. And last year at our annual society, there were 2 large phase 3 trials looking at combination therapies up front that both met their primary endpoint, with one of them being submitted to the FDA early next year. So we're really excited to say we can do better than JAK inhibitors alone. And even more exciting, in my opinion, are the immunotherapies that our colleagues in multiple myeloma and lymphoma have talked about extensively today, using the antibodies that redirect patients' own immune system to target myelofibrosis and thinking that it's some type of bacteria or parasite. So there's a monoclonal antibody looking at the calreticulin mutated myelofibrosis patients that's in the phase 1 trials right now, first in human, that just started. So we want to see those early readouts, and hopefully we'll be seeing larger phase 3 trials after that. Similarly, there are other institutions that are looking at vaccines that can even manipulate the patient's immune system to, again, target myelofibrosis. These might have disease-modifying effects that the JAK inhibitors don't. So we're really excited to see what this will show. So that was a very brief overview of MPNs in general and my approach to myelofibrosis. Thank you very much for allowing me to speak with you today, and I'm happy to answer any questions in the Q&A session. And this is just our beautiful building of the James Cancer Hospital in Columbus, Ohio. Thank you.
Thank you so much, Dr. Srisavan. I'm going to have you and Dr. Faisal for a really quick, panel discussion before we jump right into Q&A. Now, Dr. Faisal, the first question is to you, and this may be more of a perspective question than a data question. All the panelists here have presented today novel drugs and, novel therapies that are really enhancing not just the quality of life of patients, but also the duration of life of patients, right? So in this setting, when novel therapies are performing, in the myeloma space, the lymphoma space, and even the leukemia space, do you think 10 years down the line, transplant will still be a cornerstone as it is right now in many of the heme malignancies? And if so, specifically in which field do you think that transplant will still remain non-obsolete?
Oh, that's a great question. So what I tell my patient is transplant is like one of those sort of treatments that people in 100 years will read about and say that, oh, these physicians used to do this sort of primitive treatment that like the way we read about insulin being derived from like the pancreas of animals back in the days, because there was no other alternative at that time. So transplant would be something like that in future 100 years of after from 100 years from now. But at this point, unfortunately, for a lot of diseases, we do not have any better alternatives, especially acute myeloid leukemia, MDS, high risk MDS. So I think transplant is gonna stay in these spaces till we get better alternatives, and even um, in like non-Hodgkin lymphoma, T-cell lymphoma, or uh, a very select patient population of multiple myeloma who are young, or non-Hodgkin lymphoma who are young, and they have been through therapies, they have been through CAR-T, they have been through bispecifics, and they are still in relapsing, and then they are still in good shape. So transplant is your allo transplant is your sort of Hail Mary that you want to throw at that point for sure. As far as autologous transplant is concerned, for myeloma, as Dr. Hashmi has presented great data and his opinion, and I 100% agree to that. The auto transplant gives you that few extra years of benefit that you want to take for the patients. For non-Hodgkin lymphoma in younger patients, I will still keep doing it. For older patients, especially when they go beyond 70 years of age, I might tend more to do more CAR-Ts than auto now, just because CAR-T has so good data. So in that space, auto transplant is gonna fall a little, and especially in the patients now, we have definitive data that CAR-T is better than an auto transplant if the patient relapse within 12 months. So that population is like, that question is already answered in a big phase, in actually two big phase 3 trials. Um, maybe the patients beyond 12 months, like maybe we need to answer that question, like what is an optimal duration of disease control beyond 12 months for in which CAR-T do better than autologous transplant. So that's a floating question that we need to answer as well.
Absolutely. No, thank you for that. Again, I think I like your analogy in which maybe 10 years down the line, we'll be alluding to it as a more of a historical therapy that we used to do, as opposed to like, we having to resort to very intensive therapies. And my own patients who go through transplant, they come back and tell me like, did I really have to do that? And the answer right now is still yes, but we'll see how it goes. Dr. Sri Suvananukon, quick question to you. Thank you for that presentation on MPNs and, especially all the new drugs that are coming in. We have been familiar with ruxolitinib, but with fedratinib, pacritinib, and momelotinib, which you all just mentioned, I just wonder about the toxicity profile of these drugs because, you did mention that for a lot of patients, we would resort to observing them. for any sort of progression. So, would starting them on these therapies, and especially for maybe, if you, for example, if you're just treating an asymptomatic low hemoglobin or an asymptomatic low platelets, does it really warrant putting patients on these drugs? And if so, are they tolerated? What exactly are you affording these patients when you start them on these new therapies?
Yes, that's a great question, Dr. G. Thank you. And, I think that the broad answer to that is, always thinking about the patient's perspective and the patient experience, because these diseases are, especially myelofibrosis, diseases that likely they'll be having to live with for many, many years to sometimes the rest of their lives. So side effect toxicities are something that's always top of mind. For patients that are asymptomatic, that's mostly why I don't recommend starting a JAK inhibitor. But regardless of that, I actually do find that most of these JAK inhibitors are very, very safe. And maybe anecdotally, over 80–90% of my patients benefit from the therapy and don't suffer from any side effects. So actually, I reach for them quite often when I feel I need to. But certain side effects that I'm really cautious about are reactivation of viral syndromes, such as shingles and hepatitis, as well as low blood counts that I need to change the dose for. But overall, they're typically very safe.
Got it. And is it a fixed duration treatment, or is it an indefinite treatment until you see improvement?
So I typically have indefinite treatment for my patients, but there's a lot of switching therapies. And even here, with the bias of being in an academic institution, we have a lot of clinical trials available as well too. But the general paradigm is we would use it for as long as it works, or we would use it for as long as we need to get them to a transplant for a cure.
Sounds great. Well, with that, and again, being very mindful of the time and the folks who are listening in, I would like to start the Q&A session at this time. So thank you for all panelists for their excellent talks, and again, for being here. And special shout out to Dr. Stanchina, who's in the middle of inpatient service, and she rounded, presented, went back, and is now back again for the Q&A. And also to Dr. Sri Suvarna Newcorn, whose actual birthday it is today. So he set aside birthday plans to be here with us. So happy birthday, and thank you for being here with us. So Grace team, whenever we have questions from patients, happy to get started and take this forward. Okay, wonderful. I can see in the Q&A section, so I'm going to be reading out these questions and also direct them to those who are, and because I did mention to our Grace team that Dr. Stanchina is on service, Dr. Stanchina, you are going to have the first few questions if you want to unmute yourself. So first question that's in is that from a patient, how costly is the treatment for DLBCL? And and for an entire duration of their treatment, is it going to be costly? How much of it is covered? And I know as I'm reading this question that it's not easy for you to answer, but anyway, any perspective from your side as to whether patients have had significant out of pocket costs and how you mitigate that would be helpful.
Sure. So that's a great question, not just for lymphoma, but it's a great question for cancer and medicine in general, because obviously the cost of everything is increasing exponentially all the time. Just to sort of put things in perspective, I do work at both a community-based hospital. So I work at Jackson Memorial, which is mostly for Medicaid, Medicare patients or patients who have no insurance at all. And I also work at University of Miami, where patients have to have insurance to be seen. So I think, again, it's a very complicated question. To answer your question, usually for chemotherapy has been around for a long time, and chemotherapy itself is relatively inexpensive. That being said, when you add drugs like immunotherapies like rituximab, it does add cost. For the most part, even for our Jackson patients who have no insurance, we're able to get all of these drugs that are standard of care for first-line therapy. A lot of the drug companies actually have patient assistance programs, and they give the drugs for free. That being said, it does get harder with newer therapies. So our Jackson patients who don't have insurance, they are not able to go for something like a transplant or CAR T. A lot of that requires a lot of follow-up, and we need to ensure that they're able to get that follow-up, or giving them the treatment can actually do more harm than good. The same thing sort of goes with bispecifics. You know, bispecifics and CAR T, they are expensive. You know, I know the transplant on CAR T, they cost honestly upward of maybe not autologous transplant, but I know for allo transplants, they cost upward of, you know, they really cost close to $1 million. CAR T can cost over $500,000. So if you're looking at the sticker price, it is very expensive. Nobody pays that price. Like, you need to have insurance to go for those therapies, like I said, because you we need to ensure that you have the proper follow-up, or it can be pretty dangerous. And like I said, the same thing with the bispecifics. We can't give those at Jackson. They're not approved yet at Jackson. I think, again, these drugs are approved only a year ago. So with time, the treatments do change. You know, initially when the polatuzumab was approved, Jackson also didn't approve that. But now that it's approved for like 2-3 years, especially if you start to see long-term either PFS benefits or overall survival benefits, then, you know, those drugs will go through patient assistance programs and patients will get those meds.
Sounds great. You know, because this question is really important, I'm going to open up this question to the other panelists as well. In your respective fields, in myeloma, leukemia, and in BMT, do patients have significant out-of-pocket costs? Dr. Hashmi, Dr. Faisal, and Dr. Srisivannukon, you're welcome to answer.
Yeah, I will take this on actually. I think by and large, if the treatment that we are recommending is actually been a part of the NCCN guidelines, the menu, the recommendations that are updated regularly, and patients have insurance coverage, we are able to procure those drugs for patients. Usually there is an out-of-pocket cost for oral chemotherapy drugs that we use for patients, but we oftentimes have grants and fundings where if the patient is aware and utilizing those resources, that out-of-pocket cost can be $0. For all the patients that I have taken to bone marrow transplant, or for that matter, even CAR T, if they are meeting the indication, the label, I have never had any insurance come back to me and say that we will not approve it. And entire cost, including the chemotherapy, the stay, supportive care is covered by the insurance. I think the only inconvenience would be sometimes the travel from where you reside to the cancer center can have some minor expenses or more inconvenience. Even at cancer centers, the stay that happens at local lodging, Hope Lodge, for instance, is covered by the insurance plan.
Yep. Thank you.
Yeah, I can chime in. You know, in my practice, I've learned to be quite scrappy in this sense. I agree with Dr. Hamshmi that for most patients that have insurance, I really don't have a problem getting most of these therapies, including the oral agents that I talked about with the JAK inhibitors that can be quite expensive. But for patients that have significant copays, we have many different strategies where we work with a pharmaceutical company directly with patient assistance programs to get them the therapies for free for at least a year with copay cards. And then think about larger term strategies with the grants from foundations. And similarly, for patients that don't have insurance, we typically enroll them on nonprofit organization foundation programs such as Search America to get them the access for medications and follow-up as needed. So it can be challenging for a lot of these expensive therapies, but if they're on label, I 100% agree that usually insurance gives us no problem, just delays.
Yep. Great.
Yeah, so I practice in the part of the world where we have quite a significant undocumented population, which obviously is always uninsured, unfortunately. We do, and I'm pretty sure Dr. Hashmi and Rajiv, you guys can also, you have some experience in that as well. So we do find some ways of treating all the patients. Like that's the primary responsibility of a physician is to find way of treating your patients, and taking care of financial aspect does fall into our domain of practice. I will say, like, if you as a patient, you are listening and you have any financial concern, get it to your doctor, your physician as soon as possible, instead of like, do not pay so much out of the pocket that you are like broke in a year. Do not do that. You have you already have so much going on in your life. This should Like I wish we had better ways of treating in US, but we still have a lot of resources. So get it to your physician as soon as possible.
Absolutely. Thank you. Thank you to all panelists for that. And Dr. Stenchina, the next couple of questions are for you again, so feel free to elaborate or keep it brief as much as you want. The first is that, does the treatment for DLBCL have severe side effects?
Yeah, so and if we talk about like the first line therapy for R-CHOP, I do think that their patients respond very differently. And so when I see my patient, I usually tell them a lot of side effects that can happen, but I also tell them that obviously not all of these side effects are going to happen, but it's really hard for me to predict which side effects will happen in which patient. So there's some side effects that we know are always going to happen. So for example, chemotherapy in general, it can't tell the difference between a cancer cell and a good cell, right? It kills every cell that's rapidly dividing in your body. So that doesn't mean every cell is rapidly dividing in your body, but there are very specific cells that are. So for example, I tell my patients that most likely they will, lose their hair, or their hair will at least thin. In general, at the beginning, that's patients' biggest concern, that they're going to lose their hair. And I can tell you for my experience, they immediately stop caring about it. It becomes something that they just is insignificant to them. Most of the time, because patients with diffuse large B-cell lymphoma feel really bad before they start therapy. And then when we start therapy, they can actually start to feel much better. So they kind of let that one go. It does destroy a lot of the cells in your gastrointestinal tract. So you can have nausea, you can have vomiting, you can have diarrhea. One of the chemotherapies can actually also make you constipated. So when I tell them, you obviously can't have all these things at the same time. You can't be constipated and have diarrhea. I don't know which one you'll have, but the most important thing is really just being in touch with your doctor so they know what's going on with you. Similarly, we know that, the cells in your bone marrow are going to be destroyed. So the cells, like their red blood cells, your white blood cells, your platelets. Usually with R-CHOP, we don't have so much of a hard time with platelets. But sometimes for people who start with low hemoglobins, they may need a blood transfusion some point during treatment. And obviously, we know the white blood cells are always going to go low. So one of the things that we have to give them is something called growth factors, and that it stimulates the white blood cells in the bone marrow to grow. That drug can actually cause bone pain. Especially sometimes in younger patients, since they have kind of like thicker, stronger bones, they feel it a little bit more. So yes, there are toxicities associated with chemotherapy. They are all manageable. I think the most important thing is, again, just being very close proximity and like keeping in touch with your doctor so that they know how to help you when these symptoms are happening.
And that's a great segue into the next question, again, to you, because it's specific, is that what is the most important thing to discuss with my doctor about DLBCL treatment? So apart from toxicities, what would be the one other or two other aspects that patients should be asking you as a lymphoma doctor?
Yeah, so I think that's an interesting question, because I think there's what the doctor wants to talk about, and then there's what the patient wants to talk about, right? So as a doctor, you always need to explain, obviously the risks and benefits of treatment. I often find that, usually the first time I meet with a patient and we go over everything, I always tell them, you're going to forget 90% of everything I just said, right? So, and that's fine, right? So I encourage them to come with somebody. I encourage them to bring a notebook. I encourage them to write down questions. But I think the most important thing is for the patient to really understand the drugs that are being put in their body. And also, I think I must start people on 10 other like oral medications, or I prescribe like 10 medications whenever I start a patient on chemotherapy. And that can be excessively confusing, even if I go over it 3 times, right? So for you as the patient, you really want to understand, what are these drugs? What are they for? When do I take them? A lot of patients also, they have a lot of questions about diet and exercise. Can I exercise? What can I eat? Right? And these are really great questions. And I don't particularly put very stringent limitations on my patients, other than like obviously not eating any raw food, raw fish, undercooked meat, anything like that. But every patient is really different. Some people don't have a family. They want to know about support systems. Some people do have a family. They want to know, can they work? Can they be around their young children? What if their child is sick? Should they not be around their child? So really the questions you should ask your doctor are the things that are really important to you, right? Because, you know, I always say the one thing, like, I'm not the one that has to take the chemotherapy, you are. So this has to fit into your life. You need to understand the things that are important in your life so you can structure this around, you know, your values and your life.
Absolutely. Thank you for that. So, the next question I like, because this is again an opportunity for all panelists to chime in, and I welcome each and everyone to chime in as well. And the question is that, what patients are you using clonoSEQ testing in? For those who are listening, clonoSEQ is, a next generation sequencing technique that has recently been available to a lot of centers, and a lot of centers are really now adopting it as a lot of our clinical trials are now incorporating next generation sequencing testing into clinical trials for measuring what is specifically known as MRD. Now, MRD stands for minimal residual disease, or as in myeloma, we like to call it measurable residual disease because it's not minimal anymore. So, across the spectrum of heme malignancies, MRD is emerging as a very valid surrogate for survival. So, we can just go down the line. Dr. Hashmi, do you want to talk about in myeloma specifically? When are we using clonoSEQ testing? And please give us some insights on your practice.
Yes, and first of all, thank you for explaining what clonoSEQ, next generation sequencing, or MRD means. MRD means measurable residual disease. Tiny amount of cancer that's still left behind in your body that we can actually measure to the extent where we can find one cancerous myeloma cells amongst 1 million normal cells in your bone marrow. If I don't see it, I will say that you have an MRD, or measurable residual disease negative myeloma. We have known from large data sets that patients who achieve that level of remission, deep remission, tend to stay in that remission for a very long period of time. As of now, in myeloma, we know that it has a very strong predictive value in predicting very good long-term outcomes. What we don't know is that if someone is negative with this test, whether we can reliably stop all chemotherapy and say that a patient has been cured. Having said that, there are trials going on, large trials, multiple centers all across the nations who are actively investigating this question, that if a patient is MRD negative, can we stop all treatment for that patient and call them a cure? In my practice, the time points where I do MRD test is right before, after first-line chemotherapy, after 4 cycles of chemo, before transplant, after transplant, and after 2 years of maintenance. I also do it sometimes in patients who've been on maintenance for a long period of time. They are interested in stopping maintenance. I run this test. If it's negative, I actually stop the maintenance and run this test at least once a year for a couple of times to ensure that the deep level of remission was sustained even after stopping all treatment, so that I can rely on you are cured. So this is my, and use it in my.
Great, thank you. So, that's about the myeloma perspective. How about some leukemia perspective, Dr. Srisavanan?
Yeah, that's a great question. And of course, thank you for explaining MRDs. That's a very, very important point. The point I want to make here is that when we think about leukemias, we think of them in 2 large categories in terms of the biology of the stem cell. One is myeloid leukemias, and the other is lymphoid leukemias. And that actually has a little bit of answering to one of the other questions about the difference between leukemia and lymphoma. As the lymphoid leukemias, which are more in lines of the B cells and T cells, being a malignant clone, those are the ones that are more similar to lymphoma, with the myeloid being the red blood cells, the white blood cells, neutrophils mainly, and platelets. Those are the myeloid leukemias. I make that distinction for this question because clonoSEQ and MRD is really validated in the lymphoid leukemias, such as acute lymphoblastic leukemia, particularly looking at baseline evaluation, then after induction therapy, to consider switching strategies completely from like a multi-agent chemotherapy to an antibody-based therapy such as Blincyto or blinatumomab. But the same strategy has really not panned out in the myeloid leukemias, where I do most of my work, and specifically myelofibrosis. We're not using clonoSEQ for AML or myelofibrosis. So long-winded answer to say ALL is where we're using clonoSEQ.
Great. That's why, as far as data takes us currently, in the leukemia space. What about the lymphoma space, Dr. Stenchina? How and do you use clonoSEQ at all?
Yes, I do. So I think in lymphoma, maybe we clonoSEQ came into the space a little bit later than like myeloma or leukemia. But yes, I do like it for a lot of reasons. So first of all, I do like it in high risk patients. I also like it in patients who have sort of either unclear imaging at the end of treatment. Like I'll give you an example. I had a patient who was on the older side, so she was 86. She initially presented, she had a very large lesion that had destroyed her hip bone. So most of her hip bone was actually gone, including a lot of damage to the nerve. She's very hard to read her PET scans at the end of treatment. Something is always positive on her PET scans. And this is a patient that I really love to order clonoSEQ for because the clonoSEQ always comes back negative, and I get reassurance that those abnormalities on the PET scan are not from the lymphoma, right? So definitely like to use it in patients where the PET scans are not clear. I think, again, the high risk patients that I'm very worried about an early relapse. So usually, we do an end of treatment PET scan, and then we really only do imaging every 3 to 6 months after that for the first 2 years, right? So you couldn't do, technically the clonoSEQ is approved after they're done with the treatment. You can do it like once a month for the first few months. And so that can help you catch an early relapse before the imaging does. And I think it's a little bit of a gray area because I don't know that there's really good data or good guidance about what to do if that comes back positive, because unfortunately we do need to have usually evidence on a scan that the lymphoma is back. But I do think that space will also change in the next few years about how we use the clonoSEQ data.
Absolutely. And Dr. Faisal, MRD, of course, after bone marrow transplant is something that we reach out to, and that I suspect is disease agnostic, right? So how has your practice been in incorporating clonoSEQ into following your post-transplant patients?
Yeah, so as we listened about different diseases, we do like to have a MRD negative state before transplant, because if you go into transplant with MRD negativity, you're more likely to do well. Having said that, if we are not able to achieve an MRD negativity before transplant, we still we need to do a transplant. We still do it with the thinking that the patient might need some post-transplant maintenance after transplant, especially in the AML space. Again, there's not a lot of data on this topic, but again, like small retrospective studies or small clinical trials have some information on that. As Dr. Srinivasan mentioned that ALL space has much more data, but again, that is prior to transplant. So most of the use of MRD negativity is to have some prognostic information. Therapeutic implication at this point are limited, but they're being tested actively.
Agreed. And this is a space that will continue to evolve because we have more and more next generation sequencing techniques that are not just clonoSEQ, but there are other players that are entering the market, and we are able to do sequencing, that is meaning looking at cancer at depths much more than what is standard right now, and that ability is coming to most cancers. And the field is going to change in the next 5 years is our prediction, so stay tuned. The next question is kind of lymphoma focused or leukemia focused. Either one of the leukemia or lymphoma doctors can take a stab at it based on your practice. Mostly towards lymphoma, I would believe. This is a question on CLL. The patient says, I have CLL since 2018. A month after diagnosis, I developed systemic neuropathy. Several doctors do not have answers for me yet, and recently I was told that I could have potentially CIPD. Is the association of systemic neuropathy or CIPD common with CLL, and if so, what is the treatment?
Okay, so I mean, I can take a stab at it. I would say, like, in general, it's not very common, but it doesn't mean it's not associated with CLL. So the way I like to think about CLL, the same way I think about all kind of lymphomas in general, is your immune system is not functioning 100%, right? So CIPD really can be thought of kind of like an autoimmune disease that's affecting those nerves. In general, the treatment is to try to treat the CLL, try to see if they can fix the immunodeficiency problems and see if that neuropathy can be reversible. I know there can be other causes that are not CLL related. I'm definitely not an expert in those sorts of treatments beyond, trying to treat the underlying CLL. But we do see, with CLL, you can see a lot of different sort of autoimmune problems. Like you can get autoimmune hemolytic anemias, you can have, warm autoimmune hemolytic anemia. Sometimes you can have cold agglutinin disease. You can get these sort of bizarre manifestations of, regulatory problems.
Yeah, and I'll take less of a stab at that question because I wanted to mention that even though CLL, the last letter is leukemia, the second letter is lymphoid. So actually, CLL is thought biologically to be more similar to the lymphoma diseases rather than the other leukemia diseases. So at our institution, actually CLL actually is its own group because we've developed ibrutinib, but the CLL has naturally been treated by the lymphoma groups. And I would have said mostly the similar sentiments as Dr. Sanchina, but overall, there are a lot of confounding factors, and really it's hard to give you a lot of medical information without full context, and you should see your primary physician as well too.
Great. And that again neatly segues into our next question, which Dr. Srisaranokon, you had alluded to in your talk as well. So this question is about how are lymphoma and leukemia connected to each other? And I can understand from a patient perspective, everything sounds like blood cancer. What is leukemia, lymphoma? So, you talked a little bit in your talk about the evolution of cells and cell lineages. So very briefly, are lymphoma and leukemia connected to each other, and what do they mean? Do you want to talk about it?
Yeah, you're calling me out because this is a very confusing question, to be honest, and I have never really figured out a way to succinctly answer this question because it's very confusing. I mean, that's because these names are quite misnomers. Leukemia generally had meant that the blood cancer is existing in the peripheral blood. As we draw from patients' arms, that we can see many, many leukemia cells, very, very evident. In lymphoma, in practicalities, a lot of those patients have large lymph nodes that can see and manifesting as large masses, particularly in maybe the neck or in the abdomen. But as that framework, as was noted in the early days, I'm not even sure when, 50s, 60s, 70s, that framework doesn't exactly mesh with the biology underlying these diseases, and it kind of makes these things almost like a misnomer. So I think of that leukemia, there are two types: the myeloid leukemias, which are a type of blood cell, red blood cells, platelets, and some of the white blood cells, and the lymphoid leukemias, including the B cells, T cells, and even the plasma cells like multiple myeloma. The lymphoid leukemias are more biologically similar than the lymphomas. So we treat them almost similarly. And at the end of the day, the name might not even matter, because some of these treatments are very, very similar. I don't know, Dr. Sanchina, do you have a better way to think about it?
No, I think it is a really hard question. I think, one distinction I make, I guess, for lymphoma versus leukemia is sometimes the cells are more mature. So it depends along, as cells are maturing, where that, where they sort of make that mistake and start growing abnormally, right? So even among the different types of lymphomas, they actually come and, it depends where the cell, again, how mature was the cell when it made a mistake. So even if you look at the spectrum of lymphomas to myeloma, right? So, you can have cells that are in the lymph node, in the germinal part of the lymph node, we call it the germinal cell or the mantle cell or the marginal cell. And it just happens to be what part of that cell was, what part of the lymphoid organism, what was the cell in when it started like abnormally replicating, right? For myeloma, it's already became like differentiated into a plasma cell, and then that plasma cell started growing abnormally. So it's all on a kind of a spectrum. And yes, I do agree. Sometimes it doesn't matter. Sometimes it's like a nomenclature rule. So you'll see some places leukemia treats CLL. At my institution, lymphoma treats CLL. The nuances are very specific. Like, we call it, a leukemia because you can test CLL in the blood, right? So it is, part of it is nomenclature. I think also as we learn more about the genetics of each type of cancer, everything changes all the time.
Correct.
So I just like to think of it more, it's like a spectrum of diseases. And it's sort of just where along the spectrum, the cell became abnormal.
Absolutely. So, the next question that I can see is that, again, directed at lymphoma and specifically focusing on follicular lymphoma. So the question is, how often have you seen a patient with follicular lymphoma turn into another blood cancer, or the patient have two blood cancers either concurrently or consecutively? So it does seem to me that the patient is talking about the possibility of transformation of follicular lymphoma, or perhaps with the existence of follicular lymphoma, eventually developing another blood cancer. So, Dr. Sanchina, if you want to answer that.
Yeah, absolutely. So we definitely see transformed lymphoma from follicular lymphoma to diffuse large B-cell lymphoma. We're working on a project right now at our institution because we think that in South Florida, for some reason, we are seeing a lot, like a higher rate of transformation than in other parts of the country. So we're trying to figure out exactly what is driving that. In general, the rates are not concrete, right? Some places say maybe like 3% a year, maybe 30, like 1/3 of patients around in 10 years. And then other patients say, almost like a smoldering myeloma to myeloma, maybe you plateau after 10 years, right? If you don't transform after 10 years, maybe you're not going to transform. It definitely is a different type of lymphoma than a de novo lymphoma, right? Again, even in follicular lymphoma, there is a spectrum of follicular lymphoma. So you have, a follicular lymphoma grade 1, which is really truly indolent. And then you have a follicular grade 3A lymphoma, which is almost, already a DLBCL. So it could also be the more advanced that your follicular lymphoma is, the more likely it is to transform into a more aggressive lymphoma. In terms of other lymphomas, you can see obviously CLL transform into diffuse large B-cell lymphoma. We call that a Richter transformation. Again, there are some prognostic factors that we can determine to see if your CLL is more at high risk for transformation, but we really can't 100% predict who is going to transform and who is not going to transform.
Sounds great. Thank you for that. I think we're entering into a string of BMT questions, and Dr. Faisal, please get ready for the next couple of questions, and feel free to keep it as succinct as you can, because this is a live event and we need to get to all the questions. So the first question is, how are stem cells generally harvested from the donor, and what is the probability of GVHD with an allo transplant?
Yeah, so I think I kind of missed that part on my talk that maybe you should have focused. So thank you so much for asking that question. So there are two ways of harvesting or getting the stem cells from a donor. One is a collection from the blood. So the way it works, we do that for most of the stem cell collections, including auto collection, all of them, and most of the allo collections as well. So the way it works is we give you injection for 5 days called GCSF, and then that kind of stimulates your bone marrow and gets the stem cells into the peripheral blood, and we collect the those stem cells from the peripheral blood by putting 2 large bore needles or a big cannula in the neck, and it goes like the way you get or someone gets a dialysis. So we get the blood into a machine, separate those stem cells and other white cells, and get rest of the blood back to the patient. Takes about 4 to 6 hours. Collection process is definitely a bit challenging for patients who are getting an auto locus collection because they have seen a lot of chemotherapy. So sometimes those patients need a second day or a different injection to stimulate the bone marrow and get the stem cells get more stem cells out. For healthy donor, the collection usually is completed within 1 day. The other way of collecting stem cell is by doing a bone marrow harvest, which is done for, which is now in these days mostly done for benign conditions, like if someone is getting an allo transplant for aplastic anemia or thalassemia. In those situations, and a lot of pediatric centers still request bone marrow harvest. So the way it works is you go in an operation theater and put the patient under anesthesia and collect the stem cells from the hip bone by doing multiple punctures in the hip bone and collecting stem cells that way. That is being used less and less these days. The probability of GVHT, so it depends on a lot of factors. What transplant are you getting? If you have a matched sibling donor, if you have a younger donor, if you have a male donor, all these things decrease the chances of having GVHT. It still happens in around 50% of patients. Severe GVHT happens around in post-transplant cyclophosphamide era, which is the prophylaxis that we do for almost every transplant now. The severe GVHT, clinically significantly severe GVHT happens in around 20% of the patients in these days. And then for chronic GVHT is also again around the same number. We actually we want to have some GVHT, but not a lot GVHT. So when I trained in transplant, my attending, he mentioned that we want GVHT to be a switch where we can turn to a lower side than to have a button that goes on and off. So we want it to be on lower spectrum so that the graft versus leukemia effect that we see with that can be present as well.
Sounds great. Thank you for that. I'm going to say change up the order of questions a little bit because the next two questions on bone marrow transplant is a little bit generic, and I think we can spend hours talking about it, and we at this moment don't have that time. We'll come back to it, but the next question that I'd like to go into is very specific and directed to Dr. Srisuvananukorn. It is that the patient is asking that I read that JAK inhibitors have an increased risk of blood clots. Can I still use this treatment if I have had a history of deep vein thrombosis or a blood clot in my legs?
Yeah, that's a very interesting question. And, caveat, I hesitate to answer if you as the patient should use this therapy, but I'm happy to give you my perspective on that question. Now, I come from a very biased point of view in that my diseases of myeloproliferative neoplasms have a very elevated and increased risk for thrombosis because of the disease. So actually giving a JAK inhibitor to these patients and controlling the disease lowers the risk for thrombosis across multiple of these diseases. So for that question, I don't think of an increased risk for DVTs from the therapy. I actually use the therapy to make the risk even better. I believe that this question is being stemmed from the JAK inhibitor use in autoimmune conditions, including dermatology, which is something I'm actually not very familiar with. And in my very brief literature review in the past 10 minutes, it seems that in the large systematic reviews of this potentially early signal of thrombosis in the JAK inhibitors actually did not pan out in very, very large systematic reviews. So if the question is about JAK inhibitors in autoimmune conditions, I hesitate to give an answer. But if the question is about JAK inhibitors for myeloproliferative neoplasms, I'm not really concerned about that. I actually use it to make the risk better. I hope that helps.
Great. Thank you for clarifying that really important point. The next question is for Dr. Hashmi. What is smoldering myeloma and does it always progress? And for the listeners, Dr. Hashmi had talked about, the precursor states very briefly before going into myeloma, but feel free to answer this in a little bit more of an elaborate manner, Dr. Hashmi.
Absolutely. So smoldering myeloma, we still consider a plasma cell disorder. We, as myeloma physicians, many of us do not prefer to call it a cancer that needs chemotherapy. Having said that, it's a precursor condition where you do have cancerous plasma cells in your bone marrow. They make a protein. And the way we stratify that, or we divide that in three different groups, is by based on the amount of protein you're making, the amount of light chains you're making, how much cancer you have in the bone marrow, and what kind of mutations you have with those particular cancer cells. And we can divide them in three different groups. Groups with low risk of progression to myeloma, intermediate risk of progression to myeloma, and high risk of progression to myeloma. So patients who have low risk, they only have a chance of 5% chance of converting into myeloma in the coming 2 years. If you have intermediate risk, the chance is about 25% in the coming 2 years. If you have high risk myeloma, your chances of developing symptomatic myeloma that needs chemo is going to be somewhere around 50%. So really and truly, it depends on which risk basket or group you're falling in and what is that risk of progression in the coming 2 to 5 years. As one of the physicians was alluding to it, that beyond 10 years, I think many patients do not have the risk, significant risk of progression or becoming of progression of smoldering myeloma into a symptomatic myeloma.
Great. Thank you so much for that. Now, to the listeners, there are a few other questions as well. However, we have been engaging the panelists for the past 40 plus minutes on these answers. The next few questions are a little bit generic, so my preference would be that we can answer them offline for you and put them in our website. And I will read out these questions aloud, but just also try to highlight some of the challenges in answering. One of the questions is that what is the success rate of BMT? Now, Dr. Faisal, this question is for you, but I might just editorialize and mention that the success rate of BMT cannot be one single percentage to be set to each patient. The success rate for bone marrow transplant as an indication is indicated for a whole host of diseases, malignant and non-malignant. And within malignant diseases, there's at least 25 different indications. So to whoever who asked the question, being very respectful, I think if we have a little bit more of an idea as to where the question stemmed from, we can be a little bit more specific to the answer. But in general, as was mentioned in mentioned in most talks, bone marrow transplant is, right now a cornerstone in our treatment because it has been shown to stand the test of time, really be tolerable to patients, especially younger patients, and really does have survival benefit in terms of at least event-free or progression-free survival in a lot of diseases, and the gold standard overall survival in some diseases. And therefore, that is why bone marrow transplant is still being favored by us again. So it depends on the disease, it depends on the patient and the treatment used, as Dr. Faisal has just typed into the chat. The other question is that, is there any advantage to allogeneic versus autologous stem cell transplant in terms of disease progression? Again, to the person who asked the question, I think if the disease is mentioned, we can give a little bit more of a particular answer because, again, the answer would vary depending on whether it's myeloma, lymphoma, or leukemia. And the last question that is out there is that what is a risk stratification score and what does it mean for treatment? And I believe this might be directed again at Dr. Sri Suvananukon, who did allude to risk stratification in his presentation. Again, the caveat is that there is no disease mentioned in the question. So Dr. Sri Suvananukon, to just help wrap up this Q&A session, do you want to just briefly talk about risk stratification and implication on treatment?
Sure. This is a very generic answer, but stratification just means put into categories or put into buckets. And risk is highly contextual. So for each disease, the risk could be risk for blood clots, which is helpful for me in polycythemia, risk for progression to acute leukemia, which is helpful for me in myelofibrosis. We can also think about risk for relapse for after a transplant, which is helpful in leukemia. So risk is really contextual. And across all these diseases, what we typically do is make a system to say, what risk do we really care about? And how do we make a system that categorizes who's higher or lower for that outcome of interest? And does a treatment modify that risk? That's the general paradigm for a lot of these diseases, but not necessary for a lot of these diseases.
Great, thank you. And with that, panelists, thank you so much for your time today on a Saturday to spend some time with patients and caregivers here and help answer a lot of these great questions that really came in. I'm very grateful for all of you for taking the time off and for Grace to really hold this blood cancers OncTalk twice a year, which I've been very grateful to be a part of as a speaker and now as a moderator. And, a huge thank you to our sponsor organizations for their support of this particular program, which is Janssen, Lilly Oncology, Merck, and AbbVie for the continued support. And thank you so much to everyone for listening. You will have a version of these as an enduring material in the form of short recorded talks on the Grace website. So if you feel like you want to listen to these experts talk again, please feel free to visit the Grace website. Thank you all and have a good day.
Thank you again.